Hello, hello, hello. Oh wait, where is our music? Is it starting? There we go. Our music is here. Okay. Hi, GX. Second, hello. James, thank you for lurking. QQ, hello. Thank you so much for following and being the first in chat. Hi, everyone. Hi, everyone. Welcome to another episode of our podcast. This is HR Connect. Again, adulting advices and anything under the sun. We have a very interesting interesting guest today, but let me dive into what HR Connect is first. So HR Connect dives into the challenge of adulting, the ups and downs of work life, and the wisdom we can pass on to all ages in the Vtubing community. So this is a very casual conversation with our guests, and you guys are allowed to ask questions on chat. By the way, we'll be answering it from time to time. And hello, welcome to the new people who are in chat. Hello. You guys are a bit quiet right now, but I can see a lot of people lurking as of the moment. Hi. So I'm pretty sure you guys are excited. It's not common to see a VTuber doctor after all. So I hope you guys are excited as me. But let me give you guys a few interesting facts for our guests right now. So, as you guys know, our guest is an IRL doctor, so a VTuber doctor and an IRL doctor as well. He has been streaming for 6 years. He started streaming in med school with a webcam, and then he became an anime man when he started residency. So he's currently in his last year of internal medicine residency, postgraduate year 3, and also the chief resident. Would you look at that? Sheesh. He's currently applying for a rheumatology fellowship where he can continue to subspecialize over a PGY4 and PGY5 here. We'll be asking about that because, very interesting. Otherwise, he can start his career as an internal medicine hospitalist. Something interesting about him. So, technically speaking, he can only perform CPR on dead people. Imagine CPR on dead people? Huh? How? He sounds like. Why? No! He sounds very intellectual. And I am very excited to meet the man. Hi, Ikura. Hello, welcome everyone. To those who just followed, hi. Hello. And yeah, again, I'm very excited to meet him. Pretty sure he is a as someone who would say here, a fun nerd. I'm happy to introduce you guys to a very interesting person and a fellow professional, by the way. Fellow professional. I'm here to take notes. Okay, I'm here to take notes for the doctor. Okay? Alright. So without further ado, let me go ahead and welcome our guest for today. An IRL doctor and a Doctor Vtuber. Let's go ahead and welcome our guest. The doctor is in. The doctor is in, everyone. Let's go welcome Sykin MD. Let's go! Yay! Woo! Woo! All right. I'm also excited to welcome you here and wait. Hold on. Can you guys hear him? Can you speak again, Saiken?
100 HR Connect episode 4 with Syken MD.
There you go. All right, Saiken is here, the doctor is in, and we could go ahead and start the podcast. I hope everyone is excited. I can see people here very excited with what we're gonna be doing. Oh man, okay, we are going to ask questions later, but I will take note of that. And also, um, I believe you are also a fellow Monster Hunter player. Is that right? I remember. Did you play? Yes.
I mean, I'm like, I played for you and I got through like half of Iceborne.
Half of
Um
Iceborne? Okay.
I never finished it though. I actually did reinstall it because a couple of my friends have been playing recently in preparation for Wilds, but the joke is that I hate Monster Hunter because I play Lance and
Ah,
I don't do
a,
anything except I hold right trigger and poke monsters in the face.
a lance. Okay. A lance user, I see. I'm a dual
Yeah.
blade user, so.
Oh my god.
Yeah, we do the
You're the
Beyblade.
protagonist.
No, what do you mean? That's not
I
how
don't know.
it works.
I just like tanking shit.
Being a
Like just
tank.
tanking Teostra with guard up feels so good.
Hey, oh man, it's not mainstream. It's just easier. Easiest thing or easiest weapon to use. But land is also nice. I did see a couple of animations for it. But anyway, we're not talking about Monster Hunter today. We're gonna be talking about our doctor over here. And I guess we'll talk about his gaming and his stream later on. But let's get to know the person behind um this avatar right here. I actually loved your design, to be honest. The the pink bunnies over your pocket and your shirt, that is pretty cute. It appeals to probably children, you know.
Yeah,
Very
I mean
cute.
my mama went kind of hard with that. So these scrubs are actually
Uh-huh.
based off of the scrubs I wear in real life because
Really?
like
Oh.
for my references when I first asked for this, I like specifically linked the Figs Leon 3-pocket scrub top and gap in graphite and the
Uh-huh.
Figs Tansen short jogger scrub pants in graphite. And I was like, I wear these in real life. Can you make it happen? And then she was like, I
Mm.
got you. So
Oh wow, that's nice. So a couple of can you tell us more about like the design and all little details, because I've been seeing a couple of details here for you, like the thing on your arm, the stethoscope, and a few. I think there's also a purple heart on your coat.
yeah, well that was just like the Oshi mark that I picked.
Ah.
I'm
Mm-hmm.
I'm openly bisexual, so the
Ah.
Purple Heart was kind of like my nod to that.
Mm-hmm.
And
Mm-hmm.
then the stethoscope isn't based off of the stethoscope I wear in real life because I think that got lost in translation when I was talking to my mama. But it's okay. It's
Uh-huh.
I do use a Littman Classic 3.
Wow, very
I
specific.
originally had a gray model in smoke tubing, but then
Ah.
my intern broke it my second year of meds or my second year of residency. And then my
Mm.
chat ended up funding a new one on Throne, but the only one that was available on Throne was in like the mahogany color. So now I have a brown stethoscope in real life, but it's the same model.
Hey, that's cool. I didn't know that there is like, as a uh specific thing with stethoscope. I just thought it was like, okay, stethoscope, that's it. And like they came from like the same material and all. So there is differences? Really?
I mean, there's like basic ones that you can get for like $30, and
Mm-hmm.
they're like pretty flimsy. I mean, the best part about stethoscopes have to be in the construction, because
Mm-hmm.
you want to make like a nice sound isolating environment that really only focuses on what you're hearing with the bell. So I would
Ah.
say like the average good stethoscope comes out to like $100 or something.
Mm-hmm.
But nowadays there are like super stethoscopes. Like once you hit the 300 tier, Littman has one called
Wow.
like the Core 3, which
Mm-hmm.
has a built-in amplifier, like a guitar amp. So like it one
Wow.
makes the sound louder electronically, and then two connects with a phone app, and you can record. And there's like an AI murmur analyzer to listen to heart sounds and like detect different murmurs, which is like
Wow.
way out of my price range
Uh,
and probably something that I'll never need, but it's pretty cool to see.
wow. They have different functions. Wow. Okay. That is interesting. I didn't know. I didn't know that. People were learning. We're learning right away.
We're learning. We're doing the learning.
Let's let's go. But yeah, that's interesting. I didn't know. I didn't know there would be like different functions because I think most people would like see it as, it just pick up sounds for your heart and like, you know in the body. But aside from that, we didn't know that there will be like other functions um and specialties for like specific stethoscopes. Okay, that is interesting. Yeah, good to know. Good to know. So I guess some people would be like, making sure that their stethoscope are safe because it can cause a lot because of the functions, I guess. So anyway, all right. Enough about the stethoscope. Let's go ask our. So let me ask my first question here. So my first
Okay.
let's start with the conversation. So again, guys, if you have any questions, just put them down on chat. We'll try to answer them real time if we can. If it's about the topic. If not, then we'll go ahead and take note of it and we'll answer it later on. Okay. Okay. All right. So first question, Saiken, can you please tell us more about yourself? Um can you tell us who is Saiken MD?
Who is the man behind Psychen MD?
Yeah. Mm-hmm.
Okay. Yeah, so I'm Psychen. I am an internal medicine doctor, Doctor Vtuber. And yeah, current anime person on the internet. Um, like we were talking about in the intro thing, I have been streaming for about 6 years at this point. I started my first year of med school as just a way to like connect with my friends from university because I had gone out of college and went to medical school, and a lot of people in medical school didn't like playing the games that I liked playing at that time. So,
Mm.
yeah, Monster Hunter World based game, yeah, League of Legends and stuff like that.
Mm-hmm.
So this was like a way for me to kind of keep that part of me alive. I guess I've been like a huge gamer my whole life,
Mm-hmm.
and being able to stream and kind of share me having fun with playing video games was like my outlet for everything that I was still doing in medical school when that was ramping up and stuff.
Mm-hmm.
I guess I will say my one time in my third year when I was on ironically my internal medicine rotation, I was working with a resident who found my Twitch channel off of my Instagram, and then he
Oh.
was just like grilling me about it. Like he was just so confused because he was just
Mm-hmm.
like, people watch you play video games. And mind you, like this wasn't me doing it like full time or anything. Like I still only had like 100 followers and three
Mm-hmm.
viewers after a few years, but it was just like a hobby, right? So then
Yeah.
when I realized that, I was like, you know what? Maybe I should start removing my face. So then I guess around that time too, Hololive was taking off. Myth ended up debuting later that fall, and then I was like, oh,
Mm-hmm.
this is like something that like I could do to continue streaming without, needing to be public about my face, my identity. If I am going to be like a public practitioner, and like you wouldn't want patients recognizing you off of just like your Twitch channel and then like seeing you in the
Mm-hmm.
office, but also watching you like fight a Kezu, right? So I guess it took me about a year and a half to kind of get it all together. Watching other VTubers and kind of seeing how they made it work.
Mm-hmm.
Teaching myself how to use all these different apps and stuff. So that's where I discovered people like Shiori.
Ah, yeah,
Um,
sorry.
but yeah, I guess I think March 2022, I officially started like doing this stuff. I had my first debut with my 1.0 model, which was just something that I bought off Booth.
Mm-hmm.
That was back in, what was that, June? Oh God, I should know my own debut day. June 18th, 2022. And
2022 years
then
ago.
something
Okay.
like that. Yeah, and
Mm-hmm.
then I debuted this 2.0 model officially in October, beginning of October or end of September. I don't remember. Oh my God.
Very busy doctor. It's okay.
So yeah, that's kind of my how I became a streamer, how I became an anime doctor.
Mm.
Um, I ended up matching into internal medicine. Currently, I'm applying for rheumatology specialty, and
Mm.
that's something that I really do feel passionate about. It is nice knowing that even if I don't get in, though, it's like the first time in my life where I'll still be set with a career.
Mm-hmm.
Like, people don't get into med school, I'd be like, oh my God, what would I do next? People don't get into residency, they'd be like, oh my God, what do I do next? But at this point in my life, being able to apply for rheumatology, which is pretty, mildly competitive just because of the quality of life and the lifestyle of it, but
Mm-hmm.
not getting in is not necessarily the end of the road for me. And I'd still be set with a pretty nice career that I enjoy. And
Mm-hmm.
also, I mean, are like I'd still make more than like 95% of the country, so that's okay.
I see. Can you tell me about like the rheumatology? Like what is it about?
Sure. So I think the most famous rheumatology disease is rheumatoid arthritis.
Oh.
Um, so rheumatology in itself kind of deals with inflammatory conditions that are precipitated by the body's own immune system. Lupus
Mm.
is another one that some people know.
Oh yeah.
So
Mm-hmm.
it is mostly when, in simple terms, when the body is kind of sensitized to its own cells and the immune system starts attacking its own like self.
Ah,
And
so it's
that
like
has a bunch of different manifestations,
mm-hmm.
mostly in joints and stuff. That's how you get rheumatoid
Mm-hmm.
arthritis. Lupus is called the great mimicker because lupus in itself can basically present in kidneys, hearts, stomach, like lungs. It can do anything. So
Mm-hmm.
it does take a certain, a little bit of detective work and good doctoring to kind of figure out, is this truly a heart disease or is this an autoimmune disease that's just manifesting in the heart?
Okay. Okay, well that is it. So it's more of like it's always lupus. I think they said it is hard to it is hard to detect because like for example case of Selena Gomez, like they didn't know it was lupus up until like later on. So wow, okay. So like diseases about autoimmune diseases is what you are studying about, right? Right now.
Well, that's what I plan on doing. So right now I'm in residency, which is just like general internal medicine training.
Mm-hmm.
And then following this, which I find out about in 2 weeks, I find out like the first week of December actually, if I
Hey.
match to continue my training.
Mm-hmm.
So that's what I was saying earlier. If I do get in, then I'll continue studying as a rheumatologist and I'll be a specialist.
Mm-hmm.
If I don't get in, then I can still practice general internal medicine, working in a hospital as a hospitalist. So
Mm.
that's why it's like kind of nice, it's not like, oh, it's the end of the world if I don't get the specialty that I wanted because I still have like a good career set up ahead of me.
True, true. Also, getting a medical degree is really hard because, like, aside from that, it is expensive. Medical degrees are, it takes time. I think for like your course, it would take like how many years? 5 or more? I
Well, in the
think.
United States, so and the as far as I know in the Philippines, it is two most places in the world,
Mm-hmm.
medical school is actually 2 years of university and 4 years of medical school. But for some reason, the United States has an obsession with 4-year universities and the college
Ah.
experience.
Mm.
So it's 4 years of university, 4 years of medical school, 3 to 7 years of residency, depending on your specialty, and then 2 or 3 years of fellowship if you do
Wow,
end
it
up subspecializing.
takes so much time. God. But the dedication though. That is why, please trust your doctors. Some people are into, I don't know, some type of medicines, but they have studied so long. You guys should listen to your doctors. Okay. Wow. I don't know, I can't imagine like myself doing um medical courses. I think you guys have a special um what do you call that? A certain type of focus in life.
I don't know. I mean, a lot of people always say like, "Oh, I can't imagine myself being a doctor," or like, "I can't imagine myself doing XYZ." But
Yeah.
I mean, I think it's just something that I've been passionate about like since I was a teenager, and
Mm.
it's just something that I've like dedicated my life to since I was, I guess, like 15, 16, right? And I mean, like once
Mm.
you know that you want to do something, I mean, this is the only job I've had. This is the only career that I've ever wanted. So,
Mm.
like, it's not like I don't have any other choice. But I mean, if it's the only thing that you can see yourself doing, then like you would do anything you can to make yourself
Mm.
successful in that field, right? So in that regard, like I don't think I'm that special. I mean, yeah, medical school is tough to get into, but I mean, there's still like thousands of doctors graduating in this country every year. So it's about working hard. I mean, obviously, yeah, being smart, but like staying dedicated, right? Like not getting lazy with studying, not
Mm.
failing out, not burning out once you're in residency, like having a good work-life balance and stuff.
Mm. Mm. So, okay. So, okay, basing from that, I believe you have been managing so far, especially you did inserted, I know, you did inserted streaming into your life, since you are a gamer as well. Interesting. Okay. I did say, I would like to ask though, cause like, so even before, you've already thought of yourself. Okay, when I was young, I'm gonna be a doctor. Is that like how it was when you started like um going to the medical field? Is that like how
Okay,
it
well,
was, or like
okay.
something
So the
inspired
real
you?
the real origin story is that I guess I mean, I knew I was like good at like science and math and stuff in high
Mm-hmm.
school or middle school or whatever. So I always thought
Yeah.
I'd do something in STEM. Both of my parents, so my parents actually met in business school, like getting their
Mm.
MBAs together in the States.
Mm-hmm.
And then they just settled down in New Jersey and then they never left. So I I was like kind of a
Uh-huh.
rebel for wanting to do medicine in the first place because my dad was like, why do you want to be a doctor? Like it sucks. Like you're gonna work so hard and whatever. Like I'd still make just as much money with you. I mean, my dad and my mom both have like executive vice president positions and they still
Mm.
work now. Even though like I'm almost 30, like they're still working full time. So I
Mm-hmm.
mean their careers are stuff that they've grinded for and they
Mm-hmm.
probably would be able to set me up, in business like a nepotism like kind of situation.
Mm-hmm.
But I don't know, like, I guess, like, my freshman year of high school,
Mm-hmm.
I played Shin Megami Tensei Devil Survivor for the Nintendo DS,
Yeah.
and I discovered Atlas as, like, a publisher and a company,
Mm-hmm.
and after I played that game, I played the other Shin Megami Tensei games, like, emulators, but after I discovered Atlas, I discovered that they also made another series called Trauma Center, which is like a surgeon simulator kind of game where you use like surgical tools with the Nintendo DS touchscreen and the stylus.
Oh, okay.
And I played the crap out of those two games. And then my freshman year of high school,
Uh-huh.
they come out with like the spin-off called Trauma Team, which is like a full like it's like a little bit of everything. It's like you have an internal medicine doctor, an orthopedics doctor, a
Mm-hmm.
GI doctor, and like a surgeon and like a forensic detective or something. And it's like presented like a visual novel and stuff. And like anyway, I was like, holy shit, this is like the greatest game ever, and I
Mm-hmm.
played that game so much and like triple S ranked all of the missions and stuff. And I was like, shit, am I actually into medicine? Like, do I actually want to be a doctor? So I guess I would say I kind of hyper fixated myself through video
Mm.
games into wanting to get into medicine.
Wow.
But like I think from then I always knew that I wanted to, yeah, be a doctor. Even
Mhm.
in college, I was a chemistry major, but I also
Yeah.
double majored in theater studies because that's
Oh,
also like a super, fun part of my life. And
wow,
even though I did throw a lot at my theater major, like I think the end goal for me, like I always knew that I wasn't going to be an actor. Like I wanted
mm,
I wanted to be a doctor at the end of it. So yeah.
wow. Medicine, like chemistry and theater. Well, two
Yeah, I
in
mean theater
combo.
theater is just a super important part of my life too. I mean I trained as an actor, so and I've always been an actor.
Wow,
Obviously, I haven't
really?
been able to do much since, medical school, but
True.
back in
Busy.
university, back in high school, like it was a big part of my life. Definitely a big part of, who I am today. And
Mm,
I think even stuff that I write about in my personal statement for fellowship today, a lot of it, my
mm.
relationship with and my understanding of the human body, the relationship between people and their bodies, I think a lot of it is rooted in my experience in theater and my studies in, movement, dramaturgy, and all those things.
I
So
I think that's also where the VTubing comes along as well as.
probably. I mean, I think I started streaming because that was such a natural transition for me.
Mm,
Having come out of university with a theater major, you're not an
yeah.
introvert, right? But
Yeah, yeah, yeah.
when I came into medical school in a place where nobody knew what Discord was, like I felt like I still needed
Ooh.
that sort of outlet, right? So
Mm.
that's probably why I ended up streaming in the first place.
True, true. And for me, because I also had, for me, I did have theater experience. When I was studying, um, I did major. Well, not really major, but like my course relates to, pretty much mass communication, and theater, journalism, and a lot of like
Mm.
full blown stuff. So, um, I think the theater thing also helped me out when regards with acting up a certain role playing itself, and like being just out there. So yeah, the theater thing actually helps with the streaming, to be honest.
Yeah.
It
Like
helped
in
a
a
lot.
way where you can just, even if you're just like zoned out on a game, where you can just like not stop talking, just
Mm-hmm.
because it's really easy for me to translate things from my mind to like speaking.
Mm-hmm.
Like I don't know, the introvert joke is like they get like nervous when they like need to order a pizza and they start rehearsing the conversation in their head over and
Yeah.
over again. Like
Mm-hmm.
for me, I think I just have zero lag between brain and mouth.
No filter, just go on
Yeah,
and
that
yap.
too.
Okay. All right. Nice to know. Nice to relate. Because I do am like that as well. Like most of my viewers will like say, um, th- they actually has a joke. They actually have a joke with me because like everything I say, they would say that's what she said, and I was like, oh my god, why? Where?
What year is
What?
it?
What the heck? It's like how can you even translate? It is what it is, and like they would say that's what she said, and like anyway, that's that's just something I don't know. My viewers would tend to do that because like I would say random things because I wouldn't have filter about what I'm thinking.
Mhm.
Anyway, going back. So can you tell us more about your job of this time, Saikin? Because I'm pretty sure like medical school would have different types of different types of doctors. Um
Yeah.
what would you say yours is?
So, for people who don't know, medical school is 4 years. Your first 2 years is basically just an extension of university. It's mostly in the classroom, and you're just doing, medical science courses.
Mm-hmm.
So, like the medical, like pharmacology, physiology, pathology, genetics, and those sorts of like basic stuff.
Mm-hmm.
Then your third year and your fourth year are your clinical years, and that's when you're actually going to the hospital on different rotations and 6 to 8 weeks at a time rotating in different services in the hospital, to try to figure out what kind of doctor you want to be. So
Mhm.
you do 8 weeks of psychiatry, 8 weeks of surgery, 8 weeks of OBGYN, 8 weeks of pediatrics, 8 weeks of internal medicine. And you have an exam at each, at the end of each of those blocks, but it's basically to get you, a taste for what being a doctor is like in those different fields.
Mm.
So you can do more specialized rotations in your fourth year, and then your fourth year, you end up applying for residency, which is when you kind of commit to that sort of specialty. So in America, the more competitive specialties are usually the specialties that pay better than the other generic specialties. So pediatrics here does not make very much money compared to other doctors, so it is a less chosen, sought after specialty. uh,
Mhm.
on the contrary, dermatologists make a ton of
Ooh.
money. So dermatology
Mhm.
needs very high exam scores, very strong research experience, very good letters of recommendation, because they kind of get to select the cream of the crop.
Yeah.
Whereas, things like general surgery or internal medicine, like you're always going to have people that want to do surgery, you're always going to have people that want to do general medicine. So
Yeah.
those kind of programs are very easy to fill, like no matter what kind of scores you have, they will fill your spot no matter what.
Mhm.
So after you end up doing residency, which, like I said, is 3 to 7 years, internal medicine is 3 years, surgery is 5 years, neurosurgery is 7 years. Most of them kind of hover around the four range.
Mhm.
That's when you can go off and practice on your own as, like, a general surgeon or a general neurologist or a general medicine doctor. Um, or you can continue to pursue like subspecialty training too.
Mhm.
So for internal medicine, most of these specialties are, the medical specialties like gastroenterology for, digestive system, stomach, colon, pulmonology, the
Yeah.
study of lungs, rheumatology for me, autoinflammatory conditions.
Mhm.
For surgical subspecialties, I mean, you can specialize in colorectal surgery, you can specialize in thoracic surgery, heart surgery, the different types of surgery.
Yeah.
Some of the other fields like radiology, I think you can do like a 1 year fellowship, like be a
Wow.
person very specialized in reading like mammograms, or be a person very specialized in reading like musculoskeletal injuries.
Mhm.
Dermatology, you can specialize in a very specific type of like surgery that they do for skin cancer. So finally, after
Mm.
all of that, when you turn like 33, 34, you get to start your life, signing a contract and practicing medicine for the first time on your own. So
Wow.
right now, I am in my third year of residency. I'm a senior resident, so I kind of supervise a bunch of second years and a bunch of interns. I'm also the chief resident of my program, so I also am
Hey.
responsible for shit like their schedules and their sick days and all the other stuff that I don't get like that much paid for. But
Mm.
yeah, so I'm like kind of coordinating my team and what I do on a daily basis. I guess I can get into too. So
Mm.
most I think a lot of people don't know the difference between, internal medicine, family medicine, pediatrics. A lot of these are all
Yeah.
like very generalized. Oh, you're just a doctor, right? Whereas,
Exactly.
if you were a surgeon or a dermatologist or a radiologist, people kind of have a more better idea of what you do.
Mhm. Mhm.
So there are like two main faces to medicine. There's the inpatient side and the outpatient side.
Mm.
Inpatient usually referring to the hospital, outpatient usually referring to the clinic. So, internal
Mm.
medicine primarily is the adult medicine, so, 18 to, I don't know, 18 to 90 years old.
18 and
uh,
above. Yeah.
yeah, 18 and up, treating people in a hospital setting.
Mhm. Okay.
Family medicine is more just like everything, primarily in the clinic setting. And
Mm.
pediatrics is basically anybody 18 and below in the hospital or the clinic. So,
Mhm.
family medicine is a little more specialized into telling or teaching you, the things that you need to survive as a doctor in the clinic. So, you do a little bit of gynecology, you do a little bit of sports medicine, you do a little bit of pediatrics, like you kind of do everything. Like, imagine if you were a doctor in a
Mhm.
middle of nowhere town that only had one doctor.
So
Like that's kind of
everything
like
in
what family
between.
medicine, it prepares you to do that. But like for
Ah.
me, I haven't delivered a baby since medical school. So like I don't think I in any circumstance would ever be in a position where a job would ask me to deliver a baby.
Mhm, mhm.
And I kind of talk about how we treat COVID with
Mm.
regards to my job because for me, I know exactly how to treat COVID in the hospital. I know what to do if you're sick enough to be admitted. I know what to do if you're sick enough to require oxygen. I know what to do if you're sick enough to require intubation.
Uh-huh.
I don't really know, like, and or up to date on the most like advanced treatments for the clinic side, right? So if you came to my clinic and you had COVID, but you weren't sick enough to be admitted to the hospital,
Mhm.
I wouldn't know like what the most up to date specialized treatments are. Like I would probably just write something like Paxlovid and then send you home because like that's not my specialty.
Uh-huh.
I would say internal medicine is about 80% inside the hospital medicine and then 20% in the clinic medicine. Whereas something like family medicine is probably more like 80% in the clinic medicine, 20% in the hospital medicine. So
Wow.
I am very specialized to the care of adults in the hospital setting, which means adults that are sick enough to deserve to be hospitalized in the first place. I
Mhm.
do have a clinic that we still go to in residency, and that's where our clinic experience comes from. So I do
Mm.
still take care of those patients, especially the ones that we discharge from the hospital. We establish care with them as their primary care doctors,
Mhm.
but I would not say I'm specialized in primary care at all. I would probably just provide very basic sort of care at that point. But the hallmark of a really good family medicine doctor is that they can literally take care of you like from when you're a baby all the way up until you retire or something because they kind of see it all. But that is again
Mm.
primarily in the clinic. So
I see. I didn't know that there was a difference between like the clinic and the hospital side. I did have a general grasp in regards with the inpatients and the outpatient side. But um wow, there was such a difference between those two.
yeah, and I think internal medicine is a little more cerebral, like using your
Mhm.
brain more than using your hands. I think, and like I said, family medicine, being prepared to be the one doctor in the town in the middle of nowhere and kind of
Everything.
doing everything yourself,
Yeah.
like being trained to deliver babies, even though you're not OB, you're still, responsible for setting all those things up and getting the care together. I
Mhm.
think there's a little more emphasis on their procedural training as well. If
Oh.
you dropped me in the middle of nowhere to take care of, a town by myself, I mean, like, I would be so useless without my nurses. I would need my therapists. Like,
Uh-huh.
my branch of medicine is very specialized to taking care of people in a hospital, which
Mhm.
means I do need the people in the hospital to work with me to get things done. But
Mm-hmm.
yeah.
So that's why like in the hospital you guys would always have like a team instead of like cuz like if we go to like a hospital right now, for example, I think most people would generalize as going to the clinic as going to the hospital instead of
Mm,
like okay, this is a clinic and then this is a hospital, because there'd be like, hospital means you are worse sick than you would like to be, instead of like in the clinic, which is where the general sickness would be in, the first step basically.
yeah.
Mm,
So the way I think of it, and it is kind of unfair too, because in America,
mm-hmm.
people are afraid of calling ambulances because
Yeah.
of like how expensive they are to your
Oh yeah, they
insurance.
did say that. Mm.
So it's almost like our healthcare system places the burden of knowing the difference on the patient. When I've done
Ooh.
rotations in like the emergency room or the ICU, like
Mm-hmm.
people come to the wrong place for the wrong problems. And
Yeah.
sometimes that can be life threatening, right? Like people will have a very serious illness and then go to like a local urgent care, which is just a place that like bandages you up or gives you like an inhaler.
Yeah,
And they should instead go to the emergency department.
exactly. There would also be like instances like people would go directly to ER instead of like just going to the clinic, vice versa.
Yeah,
So
like I've had people come into my ER for earwax. And like,
What?
why are you coming into the ER at 3 in the morning for like earwax buildup and you can't hear? Like, you can do this during normal business hours with your regular doctor.
Mm.
But yeah, and it's just people. It's like our healthcare system expects people to know the difference, which they don't know, right? Like, if they
Yeah, they
can't
don't.
hear, how do I know that this is earwax versus like a brain tumor, right? So
Yeah.
when you kind of force the burden on the patient to suss out the difference in their own health, like because they're too scared to call an ambulance where
Mm-hmm.
somebody could help them, it is kind of unfair, and you do see a lot of people presenting inappropriately. Like, sometimes
Yeah.
I'm in the office and somebody is in danger of like being hospitalized very soon. I
Mm.
called the hospital directly and I tell them to skip the emergency room and I try to get them directly admitted to the hospital because like I don't
Mm-hmm.
want to waste any more time getting you in the wrong place, like sitting in my office taking your blood pressure
Yeah.
when your
When you
blood
should
pressure
be.
is in the double digits. Like, you should be on the floor with the nurses
Exactly.
like actively like giving you IV stuff. So
Uh-huh. Uh-huh.
yeah. But
Wow.
I don't know. I guess I can talk about like my normal day, like on the floor and
Oh,
stuff.
that would be nice. Can you tell us? Okay, doctor, can you please tell us your normal day at, at the hospital?
Okay,
Okay.
so this is residency, so I do work more than a normal doctor because I'm still in training, right?
Yeah, yeah.
A normal hospitalist works something called 7 on, 7 off. So
Mm.
they work about 7 days straight and 7 days off. Because most people
Wow.
are, hospitalized for 3 or 4 days at a time. So you want
Mm-hmm.
to make sure that you're getting the full hospital course. It wouldn't make sense to be, seeing them one day and then the next day you hand over care to somebody else, and then the next day you come back
Oh, yeah,
and
that
stuff.
that would
So
be inconvenient.
the model is to be paid for working 26 weeks out of the year, basically alternating weeks for the year.
Mm-hmm.
But in residency, because we're still training, we're working like every day of the year with like one day off a week. So,
Wow. Oh my god. And that has been going on for how many years?
oh, that's just how the system
Oh
is.
my god. Oh my god. You guys have no rest at all. Jeez.
So basically, I wake up around 5:30.
Mm-hmm.
I live pretty close to my hospital, so maybe like 15 minutes in the morning when there's no traffic because nobody else is driving at 6 a.m.
True.
Um,
Mm-hmm.
and my work day usually goes from 6:30 to 5:30 p.m.
Mm.
So my mornings, I usually, see all the patients that are assigned to me.
Yeah.
And I go through and I start just looking at their charts. I see, this is Mr. Smith. He came in for heart failure. He's being short of breath.
Mm-hmm.
His chest x-ray shows a lot of fluid around his lungs. Like, how are you going to treat him? So I kind of
Mm-hmm.
formulate my plans for what I want to do, and then I go around on my patients, which is, just seeing each patient individually in their hospital room.
Mm-hmm.
I spend anywhere from like 15 to 20, 30 minutes with each patient.
Okay.
I will say something nice about hospital medicine is that I don't have like appointments, right? So I'm not like constrained within like a 15-minute visit, right? If somebody's
True.
here for like a very simple issue, it takes me like 10 minutes to see them. If somebody is here for like a very complicated multi-organ system issue, like I can take the time, to see them, and then I'll just see my other people later. So that's kind of nice. But yeah, it's mostly just kind of formulating the plan, discussing the plan with my attending, and being like, okay, let's put in these orders X, Y, and Z. Um, the nurses will give them their medications throughout the day and then check up on them in the afternoon.
Mm-hmm.
And then usually, if this was a normal job, I could head out around 2 or 3 o'clock. But just because this is still residency,
Mm-hmm.
we're usually here like at the whole hospital, covering the whole hours of the shift. So yeah.
How long is your shift normally?
So normally I work 11, 12 hour shifts, 6 days a week.
Mm. Oh my god. How can you
And
even?
it's not, yeah, and it's not just for me too, because not only am I taking care of the patients, but I'm also
Yeah.
supervising the first years who
Mm.
just graduated from medical school like 4 months ago and
Oh
are
my
now
god.
practicing medicine. And you have to like make sure that they're ordering the right things, like
Mm-hmm.
they write 1,000 milliliters of fluid, but sometimes they'll just end up writing 1,000 liters of fluid.
Oh
or they
my
want
god,
like
that is
10
dangerous.
equivalents of potassium, or they'll write 100, and the pharmacist has to like message you and be like, "Hey, Dr. Saiken, are you sure that you meant to order 1,000 liters of fluid?" And I'm like, "No, it was, hang on, let's fix
Oh
that."
my god, that is.
Yeah, so residency kind of prepares you for everything. I mean, as an intern, you're literally putting in orders for the first time. Like,
Mm-hmm.
the nurses come up to you and they're like, "Doctor, like, what are your orders? Like, what should I do?" And I'm like, "I don't know." Like, you've probably been doing this longer than I have. But it's the volume that really gets you to the place where you are.
Mm-hmm.
I tell people, like, I learned so much more in my first 4 months of residency than 4 years of medical school, just because of like the sheer amount of patients or the sheer amount of
Mm-hmm.
hours that you spend in the hospital. Like, you pick up the doctoring very quickly.
Mm-hmm.
And whenever like my intern gets stuck or something, I always tell them, I'm like, "You learned this in medical school. Like, you just need to put it into practice. Like, you have all the knowledge. You just need to
The
make it happen."
application.
The application
Yeah.
of it.
Mm-hmm. Mm-hmm. Gally, you
So
said.
eventually, once I'm done with all of this, I
Yeah.
get to, enjoy a nice like 9 to 5 kind of lifestyle.
Uh-huh. Um, sorry. Gally said numbers are hard. So I guess, I mean, I guess it is confusing, Gally, sometimes. Putting numbers,
Numbers are hard.
a thousand liter and 1,000 milliliter. Especially like I guess sometimes they get nervous, like, interns would get nervous in regards with, okay, what should I do? This is my first time. Um what would you okay, I would ask, what would you say would be like the common thing with the interns when you handle them? Like,
I think interns just don't know how to dose medicines at
don't.
all.
Mhm.
Like, I think in medical school we learn like what drug treats what condition,
Yeah,
but there isn't that much, because guidelines are always changing and stuff. There isn't that much emphasis on learning like what the practical application of that is.
true. Mhm.
So if I'm thinking like, "Oh, this bug is Toxoplasma gondii," like the intern will say, "Oh yeah, sulfa drug, or Bactrim is what the brand name is in America." And then I'll be like, "Okay, Bactrim, how much? Like, how much do you want to dose it by? Like, do you want to do 400
Ah.
milligrams or 800 milligrams?" And they'll be like, I don't know."
So they didn't really. How so? Like when you're studying, would so they don't really specify like the dosages, or is it because it's going to be reliant on how worse the the sickness is? Is that
Yeah,
how it's
there's
done?
there's different indications, and there's different, sometimes for somebody with differing kidney function, they
Mm-hmm.
have to go down on the dose or make the medicine like every other day.
Yeah.
So dosing is actually, and again, this is why internal medicine is like very reliant on a hospital system, because my
Mm-hmm.
job also in that aspect is on the pharmacist,
Mm-hmm.
to kind of practically create the dosing regimen for the patient, because they are the ones that are kind of there to help out with the pharmacology. So, how the medicine interacts with the human body, how it's properly excreted from the human body, and like
Mm-hmm.
what you're like actually doing with it. The way I
Ooh.
kind of explain it to people is that, I know like which weapon to pick, but the pharmacist is kind of like, the gunsmith that kind of makes it all like come together so I can deliver it
Mm-hmm.
to the patient and we can use it to fight against whatever condition that we're treating. So I
Mm-hmm.
have like a general idea, like, yes, I know like we're going to use furosemide to treat this patient. Like, we can start with 40 milligrams
Mm-hmm.
twice a day. But if they're not having a good response, do I bump it up to 60? Do I bump it up to 80? What's the most appropriate for this situation?
So it's the
We can
pharmacist who's gonna
use,
do that.
it's the pharmacist who's gonna kind of guide like how long my antibiotics are going to last for, how
Oh.
long we have to treat this condition before we should step up the therapy. Something like MRSA, right? I need to order vancomycin. Like, everybody knows that in medical school. How
Mm-hmm.
much vancomycin do you order? Well, that's actually a very complicated like math equation that involves like the patient's like kidney function and their current
Mm-hmm.
levels of vancomycin in their current system in their blood. So you basically have to draw their blood every day to take a look at the level of vancomycin in there, and then
Oh.
determine the next vancomycin dose based on how much they have. So that job is actually very much on the pharmacist. So there's a reason why these medicines aren't given in the
Mm-hmm.
office, because you do need certain like daily blood draws in order to monitor these levels, because you give them
Mm-hmm.
too much, it could be very dangerous. If you give them too
Yeah,
little, you're not treating the illness.
I see. Also, that's
So hospital medicine
prescription.
in its own world.
God, there's so many things to think about. Oh my god. So,
Yeah.
so like, okay, so I have only been admitted once, and that is because of dengue.
Oh
And
my god.
yeah, it was worse. It was bad. I had like my like my blood platelets to 8.
8?
Yeah, just 8. It was
Holy
bad.
crap.
I was in the hospital for like almost a month because of that
Yeah.
bad dengue case. But yeah, I got through it, but like it got me into thinking because like they would always like draw blood on me like every day. Sometimes it would be like a couple of times for a day because they've been monitoring it. So I guess that what I'm thinking is like, so during those tests they would be doing match it and like, okay, this is what my medicine is going to be for the next days. So is that how like things are happening when you get admitted? Is that
Yeah, like a lot of medicines are kind of like that. Like you can't just give the medicine forever, right? You don't need
yeah.
the antibiotic forever, or you don't need, these fluids forever.
Mm-hmm.
So, kind of using your clinical judgment to see how the patient is doing. There are different labs that you can get to see what their inflammatory response is, how well their immune system is functioning,
Yeah.
and, how good the patient looks at that, right? I mean, so, for context, like if well, one, okay, we never see dengue in North America. Like it is very much like that's why my reaction was like that. Like that's like dengue, holy crap! But I guess
Yeah,
it would
it
be
is
quite common
common
in the
here.
area you're at.
Yeah,
Yeah.
because tropical country. um
So for me,
mhm.
like the things that I learned in medical school about dengue is like not the stuff that's relevant to treating dengue. Like for me,
Ooh.
I know, okay, like what goes on in my brain when I hear dengue, I
Mm.
hear dengue, the virus is a single stranded, positive sense RNA virus in the
Mm.
flavivirus family, transmitted by the Egyptian Aedes mosquito. Uh,
Very, very.
like incidence is in tropical areas in the world.
Yeah.
And it basically, lives in your bone marrow, replicates bone marrow, causes plasma leakage by increased capillary permeability. The symptoms, body aches, breakbone fever. You have this erythematous maculopapular rash, these minor hemorrhages, plasma leakage.
Mhm.
How do I diagnose it? I diagnose it by getting antibodies to the dengue virus that are in your bloodstream. I'm looking for low platelets, low white blood cells, liver enzyme elevation, decreased fibrinogen, blood in the urine, occult blood in the stool. Differential diagnoses. It can be, Zika virus. It can be
Mhm.
chikungunya, and treatment, right? Like fluid resuscitation, pain control, close monitoring. I can say all of that off the top of my head,
Oh my
but
god.
none of that really goes into taking care of a patient with dengue fever, you know? Like,
What the
how
heck?
much fluids do I give? How often am I supposed to check their temperature?
Mhm.
How do I tell the nurse like what the warning signs are to look for? How often should I be checking their urine? How often should I be drawing their blood and these sorts of things? Like, I basically have like a very, very generalized top down overview of like the course of the disease,
Mhm.
but I'm relying on my nurses to assess the patient every 2 hours, and be able to see, like, okay, what symptoms are they developing now? What do we need to address? I'm relying on my pharmacist to be like, okay, this is a good regimen that we have right now. The blood cultures are also growing this. Do you want to start this medicine? I'm relying on my social worker, to think like, okay, like this is a 70-year-old grandma. Once you treat her, she's not going to be able to just go home. She's going to need to go to a rehab hospital, do physical therapy,
Mhm.
and kind of get back on her feet. And, thinking about discharge planning and what does it look like after that? Does she follow up with the doctor outside of the hospital? So my job in internal medicine is almost like very Overwatch, like making sure that all of these different bases are covered. And when I tell my interns to put in the orders, like making sure that they're not like clicking the wrong thing.
Oh my god. Okay.
So yeah.
I mean, first things first, I'm oh my god, you just stated that for like you are very book smart. Like when you said like you freaking just described Dengen like top down. I was like, what? He knows that book description right
Right? And I've
away.
never
What
I've
the
never
heck?
treated dengue fever. Like I have never experienced a patient with dengue fever in America here. Like it's
Really?
just one of those things that you learn about in medical school.
Oh my god. But still, I'm amazed. You just described dengue and like what right away, like snap, this is dengue. Oh my god.
I mean,
Okay.
this is probably like the second time I've thought about dengue since medical school.
What the
So,
heck?
but like that's the thing. It's just we have our knowledge as a
Mm-hmm.
physician is this very broad strokes kind of overview, and there's a lot of like little parts that goes into actually physically delivering the care to the patient that we honestly like are very hands off about.
God. Okay. All right. I'm trying to guess everything. Every
Yeah.
Okay, Sour Sweets here said medical field is just big team that has to work together to do what's best for the patient. I think that's true, but what would you say, doctor?
Yeah, definitely. I mean, the more that I work in the hospital, the more that I realize, how not unimportant I am, but how little I actually
Mm-hmm.
like I can do on my own. Like the first thing I said was like I'm useless outside of a hospital because the conditions that I treat, like I can't send somebody home and tell them to follow up with me again in a month, right?
Mm-hmm.
Like the conditions that I treat require like very active checkup on the patient throughout the course of a day. Like somebody can be okay in the morning and then die in the afternoon. So I need to like be able to keep tabs on those sorts of things. For me, a hospital doctor probably takes care of about, I would say, 20, 22 patients a day. And a nurse takes care of like 6 patients a day. So just for context, I mean, the nurses have so much more time with the patient and have like so much more contact and, physical assessment of the patient. A lot of my work is relying on the reports from these different people to see how we can treat them better. So I'm getting reports from my nurses. Oh, this patient she's not like able to swallow. She keeps, coughing up the water. She can't take her pills. Okay, like what do we have to do? Now I have to consult our speech therapist and get our speech therapist on board and see is there something like a defect in the patient's swallowing ability. Oh, one of these medicines is like a seizure medicine. Now I have to change that medicine from oral to IV so that the patient can still get it as a time critical medication, even though she can't swallow. Now, oh, the conversion from oral seizure medicine to IV seizure medicine is different and requires like increasing the IV amount or increasing the by a factor of 1.5, and the pharmacist like catches my ass and say, "Hey, like make sure it's not just 500 of this medicine, it's actually 750 of this medicine." And I'm like, "Okay." And then I put in the order in. So it's like I know the things that we need to do to treat the patient, but if the patient can't swallow or if the patient can't get up or if the patient like can't physically go to the MRI because they're claustrophobic and they can't physically lay down for 2 hours in the scanner. Like there are all these little things that pop up that I just would not know unless I had the people around me to help me.
Wow, that is something. Rika says, "Thank you, Doc, for acknowledging nurses and other specialties. We appreciate you." Oh,
Yeah, I
that
think
is
I
that is so
think
sweet.
internal medicine is just one of those things that, you just appreciate the hospital more because you recognize how powerless you are outside the hospital. Like I think a lot of people like think that there's a stereotype of like
Mm-hmm.
doctors like ego checking nurses, being like, "Oh, you're just a nurse. What do you know?" right? Or
Oh,
like
yeah,
well, if
there are
the nurse
that.
didn't deliver your order to the patient wouldn't get better in the first place. And there's so many things about nursing that I'm just ignorant to too, right? Like I was talking about medicines, right? Like delivering
Mm.
the vancomycin for a MRSA infection. I don't know how to like deliver vancomycin. Like if
The
somebody
nurses would
handed me a
know.
bag of the medicine and told me to connect this bag to the pump and connect the pump to the IV, like I don't know, like that's never been my job. Like I only know how to treat the patient. I don't know actually how to physically put the medicine inside the patient.
Oh my god, a lot of Yeesh. Such a team would be doing that then. Okay, I'm saying
Yeah.
a bit of an overview of like what your job is. So basically you um okay, plain description would be like you oversee everything from top down. Is that how your work is as a chief resident, right? And
Well,
like
I mean,
with doing
as so in resident, like in general, yes, that's how like a hospitalist, like a hospital doctor, works in internal medicine. That kind of top-down view, spending about 20-30 minutes with each patient and, assessing these problems.
yeah.
Problem number one, we're going to do XYZ. Problem number two, we're going to do ABC. Right now in residency, it's just mostly about training. So
Mm.
I'm not only continuing to take care of patients and for my own learning, but I'm
Mm.
also responsible for teaching like my underclassmen
What
who
you're
just
learning
graduated
is
medical school, and I'm also learning at the same time.
yeah.
So it's a lot. And then as a chief resident, I'm also like responsible for like sick days and vacations
Sheesh.
and schedules and
And the
backups and
schedules
like all these
too.
stupid things. Yeah.
My god. Our doctor is very busy. Please appreciate. Oh yeah, wait. I have a quick question because you did say okay. One last thing before we move on. Um, so you did say that you only do CPR on dead people. Can you tell us more about that? That is interesting. I
So, yeah, I mean, you see CPR represented on like TV or whatever, and it's like never done correctly.
yeah,
Um,
the pumping it should be like there
like
is a
it
proper
needs to be aggressive. So,
yeah.
I mean, this is off the American Basic Life Support and Advanced Cardiovascular Life Support algorithms, and these are American entities. So, I mean, I'm just saying this for the stream audience. But yeah, so CPR is cardiopulmonary resuscitation, and the act of those chest compressions in itself is to physically pump the chest so that the heart is squeezing out all the blood that it can. You only do this if somebody's heart is not beating or they don't have a pulse, because that means their heart is not delivering blood to the rest of their body, to their brain. So, in that sense, that person is technically dead. Therefore, the
Oh,
adage is CPR is only for dead people, as in you should not do CPR on somebody who's, awake in respiratory distress, somebody who can't breathe. Hey, if you're telling me that you can't breathe and you're like coughing and choking, that means you're alive. Like that's a good thing, right?
oh my god.
If I see somebody collapse and their heart's not beating and I don't have a pulse, that's when I start doing CPR. That's
CPR.
when I start aggressively pumping their chest. Yeah, and Gally is saying gotta break them ribs. So the correct method of doing CPR with the chest compressions, like you do want to go down, actually chest compression depth. There's actually a number. Like you do want to go down between 5 and 6 centimeters into the chest to really pump that heart and make sure that you're getting as much blood flow as possible. And 5, 6 centimeters, I mean, maybe in you or me, we'd have a lot, like some rib pain once we wake up. But, in older adults, right? Like, think about your grandparents, 5, 6 centimeters, like, you probably are going to be crushing ribs and breaking ribs in order to get that done. And, you or me probably would not be in a position where we're, collapsing out of nowhere and not having a pulse. But in the hospital, this happens to the grandmas and grandpas all the time.
Oh my god.
So when these people don't have a pulse, they call a code blue overhead. I mean, you got to get in there and start pumping on the chest. And when you do that, you do, feel that crunch of ribs under your hands. But your hands are the only thing that's keeping their heart beating at that point. and like they are technically dead. So you have to be as aggressive as possible in order to, bring them back and keep the blood flow to their brain, keep the blood flow as much as possible until, you hopefully resuscitate them and get their pulse back.
Well, so wait, so it is true that you gotta break them ribs
You
to.
do.
Oh my god. Oh my god. Okay, interesting. Okay, because
And we ask this before any patient is admitted to the hospital too. I always say, it's a legal question a lot of the time, but if for any reason, God forbid, your heart were to stop during this hospitalization, would you like us to do everything we can to, keep you alive? So, this includes
Wait,
chest compressions, shocking you with the paddles, to try to
uh-huh.
restart your heart,
Yeah.
intubating you and putting you on the breathing machine in the event that you can't breathe on your own. So it is a lot for somebody to still want all of those things because, if you are 80, 85 years old coming into the hospital, those aggressive interventions might not be the best thing for you or your family, mentally, emotionally, financially. So that's always something that I encourage like older patients, coming in with very serious things to talk about with their family because, in the worst case scenario, those things do happen. I can keep somebody alive in the hospital, quote unquote alive, for a very long time, right? Like if your heart doesn't beat, I can restart it. If your lungs don't breathe, I can make the machine breathe for you, right? I can give you medicines to maintain your blood pressure. I can give you medicines to, keep you alive, quote unquote. But sometimes that's just not the best thing for somebody. So
Oh my! I didn't know you
it's
guys
always a
asked that.
conversation you want to have.
I
I
wait,
mean,
wait,
you
wait,
should. I don't
wait,
know if you you guys are doing it over
wait,
there, but you should.
wait. I don't. Okay, wait. I don't think that's being asked at all. Like, wait. Okay, this is the first time I'm hearing that. Hold on. Okay. Because okay. General public would just know that okay, it's the doctor's job to keep you freaking alive. So but what you guys ask? You have to get permission for that. What the heck? So
I
like,
mean, do you guys have the concept of a DNR over there? Do not resuscitate.
yeah, we do, but like there would be just certain circumstances. For example, like people with the blood thing. Like if you are in this religion, you can accept blood and such stuff. But like, I don't think the general public would know that there is some limits in regards with okay, you would be asking a person as you said, especially like older people that are you okay with doing a with us doing this and that. I don't think that's being asked at all. Like I have never heard someone ask that.
Yeah, I mean this is like, I maybe they do and you just don't know. I mean, because I'd
Okay.
imagine when you were admitted to the hospital and treated for dengue, I mean you were still quite young, so of course, like, yes, do everything to keep me alive, right?
Yeah. Oh my,
But for somebody
we're
that's
old
in the
people.
ICU and treated like this aggressively, in an intensive setting, like 1 3-week hospital stay is gonna take you like a few months to recover from. And that's like, a young adult, right? Now think about it, if you're 60, if you're 70, if you're 80, you are in a very frail condition at baseline.
Yeah.
Getting patients and families to understand, the improvement that could happen after they get out of here for such an aggressive, illness. Sometimes the quality of life or the emotional burden on the family, the physical burden on the patient is not worth prolonging that sort of suffering for. I had a 90-year-old patient in the hospital the other day with like a perforated ulcer. So like he had a hole in his stomach
Yeah.
and he was, septic, looked terrible, needed emergency surgery. And, he very rightly understood, like, yeah, like this is going to be a long and arduous hospitalization. If this surgery like if I don't wake up from the surgery, if something goes wrong or if I am not in a position where I will get better realistically by the time, I already turned 91, you
Mm-hmm.
know, like sometimes it is more appropriate to say like if something happens to me in the hospital, do not go through the pains and the lengths of keeping me alive, hooking me up
Just
to the
that.
tubes and the machines, just let me go. And I
Ah,
think
okay.
that's always something that we try to encourage families not to force on the patient, but to just think about that sometimes it is more appropriate to have that conversation before something happens because there have been so many times when I've seen, older patients kept artificially alive, family members arguing like, "Oh, we pulled the plug. She wouldn't want to live like this," or "No, grandma's a fighter, like we can wait for a miracle." And, basically just squabbling while the patient is just sitting in the ICU, zero quality of life, essentially like on death's door, but we are keeping them alive for the family to make a decision. And that's always just a super frustrating part of the care because I don't think a lot of people understand what comes with the phrase do everything you can. Because, like I was saying earlier, we really can do a lot of things to keep somebody alive for a very long time.
Mm-hmm.
But, like,
Machines
with
can.
that, it's just not, that's not life to a lot of people. And a lot of patients don't know what they're signing up for when they do that. Yeah, if you're 20, 30 years old, you have COVID, you're in the hospital, you're, in the worst case, intubated, and then you come out fine and you do physical therapy, occupational therapy. It takes about a year to get back to your baseline. I mean, that's fine. You're a young adult, right?
Mm-hmm.
But, the older you get, that 1 year turns into 5 years. That 1 year turns into 10 years. If you have a
Wow.
stroke when you're 40, you can probably recover by the time that you're 50.
God, it
If you
takes
have a
time.
stroke, if you have a stroke when you're 80, are you willing to go through all of that therapy and everything,
Mm-hmm.
by the time that you're done? I mean, you
Yeah,
might not have the energy or the strength to do those things. So,
I got you. Okay. Okay, wait, okay. I guess I understand now. Got you. I think it's just more on like they would not ask you that like right away, but you did explain that at certain point of like the medication they would be asking you or the family member. Okay. We got you now. Thank you. Thank you, doctor,
yeah,
for
so I
explaining.
think for a hospital doctor, it's important to be upfront with it, like
Yeah.
plan for the worst case scenario in the beginning,
Uh-huh.
so people aren't having to deal with these conversations in when something happens and goes wrong.
Mhm. Got you.
For a clinic doctor, yeah, if you're stable enough to follow up with me in 6 months, like good, that's fine. As long as you don't get into a car accident or fall down the stairs or something, like I expect you to be the same way as I saw you 6 months ago.
Got you. Perfect. Thank you. Hi, Carl. Hello. Thank you for thank you for dropping by. Also, those question. Oh man, I'm seeing you. Behave. Those. I mean, he will answer. He answered, but like, God. Oh my God. Okay. Behave, people. Please ask appropriate question to our doctor right here. Professional questions, please. Thank you. Um. Anyway. Um. That's fine with you though. All right. Anyway. All right. Let's go to the next question. We actually learned a lot from that one, and thank you so much for giving us, you know, for giving us a lot of information about the medical field. I think I understand a couple of things now. A couple of things better. Um. Okay. Another question would be, um, since you had since you've been in the medical field so far, have you ever think of like if you were not in here, where would you think you will be?
So I mean, I told you I was a theater major, and like theater was a super popular, thing in my school, and it was just something
Yeah.
that I was really passionate about. And that's like a huge kind of keystone in my life. So I think if I wasn't doing medicine, I probably would have tried to become an actor.
An actor?
There are a
Oh.
few from my cohort in university that have gone to be professional actors.
Mm-hmm.
A few of them, made it big on like, you know, local sort of productions in like
Yeah.
the bigger cities. One of them is on like a Netflix show. Like some of them are now like playwrights in New York, and
Mm-hmm.
like, or they're like a writer in residency at like different other like universities with like big arts programs. So I feel like I could have followed that path as well.
An actor instead of a doctor. Oh.
Yeah.
Okay.
I mean,
Well,
I'm a pretty good actor, so
I mean,
I just can't sing. I can't do musical theater. I can't sing for a shit.
so just so just a
Just
drama.
plays.
It
Yeah.
plays drama actor. Okay, got you. Thank you. Okay, that was a quick question. All right, I won't press on further on that because I think so far you have been enjoying your, your residency, um, your medical field. Okay, Rico is asking, what's your favorite musical? He says, Gali says you're a rap
uh,
god. Is that true? Are you a
I
rap
mean,
god? Really?
yes. No, it's the VTuber thing. You gotta do covers.
What?
You have to. That's everybody does it. You can't be a VTuber if you don't release a cover every 6 months and spend way too much money on it for a YouTube video with 400 views. Anyway,
Oh my god.
wow, favorite musical. That's crazy.
Oh yeah. I love musicals, but what would be yours? Do you have one, or would you
Uh,
just or would you change that to what's your favorite um play?
my favorite play is Uncle Vanya by Chekhov, for sure. Um,
Mm. What is it about? I haven't heard about that.
Uncle Vanya.
Yeah, yeah.
It's like a classic, like I don't know. It's a drama. It's just like family drama, like older man and like in crisis with his brother's like
Mhm.
wife, and it's just like all of this like tense feelings and relationships, and
Oh.
it's just like
Seems like
very
an
beautifully
intense
written.
drama.
Yeah, it's from like 1900 or something. Like
What?
it's a
19?
classic.
Okay, I will search for that. I have not heard about that, but thank you.
Vanya, Uncle Vanya.
Uncle Vanya. Okay, got you. Rico's a strong choice. Wait, do you know that as well, Rico? You know Uncle Vanya?
Like this is such like a theater major answer. Like people don't like watch Uncle Vanya like it's fucking Hamilton or something. But like people who have actually like studied theater in an academic context will probably like appreciate that.
I have not heard about that, but like um I did know. I think if I'm gonna be asked for like a play, what's that title again? It's the one with the 10 men something. What's that?
10 men,
12 Angry
angry
Men.
men.
There you go. That one.
Yeah.
That one is
You mean 12 men?
yeah, something. Oh my god, I'm bad at naming things, but like 12 Angry Men is, I think, would be my um favorite. Well, yeah, a favorite of mine as a, it's not a musical but a play. It just brings out a lot of like moral stuff for people, and it's just, I don't know, the conversation and like um the conflict itself is interesting because it would make you think. So yeah, 12 Angry Men for me. I think we did a music. I know we did had that play in our school as well. So it was fun seeing them argue in one room and like, you know test out their morals. It was fun. Dead of a Salesman is my jam. I think I heard about that. Anyway, no musical. Saiken? Just
I don't know. There are
Uncle.
too many. I can't. I mean, like as a theater kid, I have
Oh,
to. I don't
come
know.
on. You should have one.
Okay. Wait, niche, really niche pick.
Uh-huh.
Uh Really niche pick. I like Bat Boy.
Bat
It's like a
Boy?
rock musical from like the fucking, oh my god, when did this come out? It's like a rock musical from 1997, and it's just like so aggressively like 90s glam rock core. The story is not even that great, but the songs are just
1992.
fun. The songs are just really fun. It's like very of that era.
Oh, okay. Oh my god, why does it look
Musicals are too
so...
easy though. There's so many like jukebox musicals and stuff. Like American Idiot is a musical. That's a good
Yeah,
musical. I like
that is a
that.
good musical.
Like I mean, but that's not necessarily like an original work. It's just the Green Day album. But I like how it's staged. I really like the scaffolding and the direction of like the stage design and stuff. But shit, I really do like American Musical. Like unironically, I really do enjoy that as a musical too, as a musical performance. Oh no, dude, Bloody Andrew Jackson is also a really good one. Oh, okay, there are too many musicals.
Too many? Okay.
There are too many musicals.
Too many musicals to think about.
Well, that's the thing, because it's like musicals have like, you know, in that like early 2010s era of Tumblr, like everybody like had their one favorite musical and stuff. Like people talk about musicals in a way in like pop culture that they will always be relevant.
Yeah.
But like something like academic theater study, like the Furies or freaking Uncle Vanya or Master Builder, like these classic like plays that you really only read like in your theater classes. Like nobody's gonna like hyper fixate on those like they hyper fixate on Hamilton. So
True. I mean, Hamilton has its effect because like it's pretty much kind of brand new. Like it gives out the rap and like I don't know. It has
brand
everything.
new. You know, Hamilton's almost 10 years old at this point, right?
I know, but like
Isn't that crazy?
Oh my god, it feels like it doesn't feel like 10 years. It doesn't feel like fucking 10 years. Hamilton is still jam. Oh my god. I mean I think one thing I like about Hamilton is the rap and how they incorporated the story within the rap. You know, that's not something that a lot of musical would do because like more or less like they would do either a classical, a pop thing, but not entirely rap. So it was interesting. Why would you age us? Who did say that? Greco? Saiken is not 30 yet. See, he said. He's still young? What do you mean?
I'm not even that old.
You're not old. I mean, I'm not that old, so. But regardless. Anyway, okay, moving on, people. Thank you for giving us a quick, you know, a sneak peek of not Doctor Saiken.
Yeah, like I really want to get back into acting. I mean, besides VTubing being like my substitute for it in the meantime.
Yeah.
Like I would always like my fantasy would, you know, being a rheumatologist, going to clinic, coming back home at like 5, but also being able to be in like, you know, community sort of productions, like not a professional actor, but
just
some sort of like local playhouse or
doing it on the
just
side.
being like doing it on the side just because it's like something that I enjoy.
Bro, would you even have time?
Yeah, I mean that's the thing. Like I would be like an attending. Like I would be letting the residents run my stuff at that point.
Well, imagine. We'll see. Maybe it's possible, you know.
Yeah, this is like another 10, 15 years down the road.
We'll never know. Okay. All right. Next question for us. All right, let's move because oh my god, it's already 1:30. I'm so sorry. Okay. All right. We did ask this one. Okay. You did say what made you decide. Did you already wait? Have we asked you what made you decide to be a Doctor Vtuber? Like
I mean you and I kind of talked about it, but
okay, share it, please. Share what
share with the class.
Yes, please share with the class what made you decide to be a Doctor Vtuber? Because like,
Yeah.
what was your thought process of like, oh, what if I become a Vtuber but a doctor like my profession? So.
So like what I was saying earlier was that, I did want to switch to VTubing because, I saw this platform was kind of taking off. I
Mm-hmm.
did start, watching Hololive, and like my Oshi is Hatama, and I liked watching, like, back then. I also liked watching Botan and Pekora as well.
Uh-huh.
But then Myth debuted that fall, and that's when I was like really like getting into it on the English side, and like seeing that there were like a lot of streamers like just on Twitch using VTuber models and stuff too.
Mm-hmm.
So when I thought about how I could, continue to stream, but also not showing my face and not, being a public doctor and public streamer, I was like, oh, I could just, use this as a way to continue streaming just like how I had originally been.
Mm-hmm.
And then because it was always about me, I was just like, well, if I want to still be who I am, I probably shouldn't like try to be something that I'm not. Not that I thought it was like Chuny or something, to be like the
Mm-hmm.
time traveling detective or the
Yeah.
Grim Reaper or whatever. But it was just like, I mean, I did start streaming as a guy who was in medical school, so I might as well start streaming as a VTuber who's in residency. So I mean,
Mm.
I think my concept is like unironically unique enough because it's not like there are very many doctors who are VTubers.
Yeah, 'cause there's
And
very
then
few of
lo and
you.
behold, like early 2021, as I'm planning on how I could do this thing, I
Uh-huh.
discover Shiori Pon, who is a Filipino surgeon and surgeon VTuber.
Yeah.
And then watching her, I realized like, okay, wow, like people actually like meld these two things together. Shiori
Mm-hmm.
also does a bunch of medical education content, which is like stuff
Yeah.
that I've kind of put my toes into, but I haven't really released that much content about.
Mm-hmm.
And I've always kind of like looked up to her as my idol in that sense.
Aw.
So I've always been like, yeah, like that's something so cool. That's something that I would want to do. And then
Mm-hmm.
I picked up like a model off of Booth in like around Christmas that year, and then I started like downloading B2 Studio and like doing all the
Yeah.
things, and like my debut in March, yeah, and then eventually a year and a half later I got to commission my own model,
Mm-hmm.
and yeah, the 2.0 debut, which was like 2 months ago. So
Aw. That's nice to hear though. Okay.
yeah.
We have shared to the class. But it's actually nice to, or do you plan on having more medical discussions with your community aside from, you did say you did dive into it earlier.
Yeah, so I mean, I've done a few streams, talks on like applying to medical school, like
Yeah.
navigating being pre-medical in college. I
Mm.
did a collab where we talked about what we were talking about, like do not resuscitate orders, and like what are your options when you form like an advanced directive,
Yeah.
encouraging your older family members to have these
Mm.
conversations before the worst case scenario happens. Things like hospice care, palliative care, physician assisted suicide, all that stuff.
Mm.
I have a few pieces like on my TikTok and my YouTube that's just like
Hey.
general medical stuff. So I have one episode on heart failure. I have another episode coming out on heart attack versus cardiac arrest.
Oh,
Um,
that's
so I
nice.
mean, it's something that I'm trying to do, but I certainly don't do it regularly enough.
Do you
So because
plan to though?
I am still studying myself. I mean, I do stream like doing questions for board review and stuff
Yeah.
because I do have to take my licensing boards later this year.
Uh-huh.
So that's like my excuse for how I'm doing medical education, but it's not like I've done much where I sit down and just kind of lecture
Uh-huh.
people on like things to look out for and stuff. For me, lecturing is still about learning the stuff that I need to know for when I take my board exam. Oh yeah, the
Mm.
lupus presentation. Okay, so I did a whole 10-minute presentation on lupus
Yeah.
for like this Iron Mouse community stream.
Oh, yeah, I saw that.
And she was just like, "Hey, submit your 10-minute videos," and then I'll watch them on stream,
Uh-huh.
and the I did not make the presentation for Iron Mouse. Like I just made the presentation for work because I had to give a presentation at work, and
Uh-huh.
then I just changed it a little bit and then did it with 10 minutes with my VTuber model. And then it's like it got selected and I was on her stream, and then that was pretty
Hey.
cool because a bunch of people like started following me from that.
Uh-huh.
So I think if you go to my Twitch channel, like I set that clip as like my channel trailer because I was like, dude, I fucking peaked in that moment. But yeah,
It was a
it's not
nice
like I've
moment.
done content like that. Yeah, like that. I guess that is the kind of content that Shiori does, and that would be like the kind of content that I would love to do more of.
Mm-hmm.
But I don't know. For me, it's mostly still about studying for myself, just because I'm not like independently practicing yet. Well,
Mm-hmm.
I think when I do finish residency and I do have more time, I mean, that's something that I would want to transition to. But I think right now, a lot of my brand, per se, as a Doctor Vtuber is just, what it's like in residency and stuff. I mean, you watch TV shows about like residents living this shit life, working
Yeah.
80 hours, 100
House
hours a week,
empty is
or other things like there's stuff that like it's real, but it's a little exaggerated. But I mean,
mm-hmm.
I still worked like 74, 75 hours the past couple of weeks, but I still had
True.
time to stream and make stupid shit posts on Twitter. So I mean, I was just trying to show people like my life and like the stuff that I enjoy and how I can continue to enjoy them even though I'm undergoing medical training.
I see. Well, good to hear at least that, you know. I actually like the clip as well. I watched that and I was like, "Oh, wait, I know that one. I know
I know
who
that
the I know
guy.
that guy. Wait."
That's oomph.
And like, I mean, I would love to see you discuss more medical stuff as well, cuz I don't know, like right now, like hearing you discuss it, I think I am hooked. And I'm like, "Oh, I have a lot of questions. Wait."
Yeah, I think a lot of people like, and especially in our generation,
Yeah.
like they just don't think that they could be sick, right? Like, yeah,
Mhm.
my parents are sick, like my uncle would get sick or they're on medicines, but like I'm not even 30, like I couldn't possibly have anything wrong with me, but like you probably
Yeah.
have friends that go to the emergency room, friends that like something has happened and given them like a health scare. And I think just like being more on top of this, I have so many friends that just have not gone to a doctor's appointment since they were kids. And I'm just like, why? Like,
Oh,
how are you okay with that?
exactly.
Like,
But
nobody's like keeping up with you or your labs. Like, you could be anemic and you don't even know it. You could have an iron deficiency and you don't even know it. Like, they're just even if you're just there to get a checkup and somebody listens to your heart, like, when was the last time somebody listened to your heart, right? Like, what if you developed a murmur in the meantime, or maybe you
a,
have AFib and you just have no idea?
a lot of
So
people
I think
are
encouraging people, especially in the VTuber space, which is like
mhm.
a younger audience, I think, to be more
Exactly.
active and participate more with their health, especially since we're in this era of like wearables, like Apple Watches and Fitbits,
Oh, yeah, I got
and
that
they
one
can
too.
recognize things like AFib
Exactly.
or skipped beats and be like, oh, maybe I should talk to a doctor about this. And people are just like, "Oh, I don't want to make a doctor's appointment. Like, I don't want to see a doctor,
I
blah blah
think
blah." I'm
I
just
think
like,
they have
"Dude,
the
it's
mhm.
it's people like us. It's people that are like the doctors now are going to be people that's your age. Like, you don't need to make such a big deal about it. Like, I'm here to take care of you and it's okay. Like, I can explain these things to you. Like, I'm not some stuffy professor or
Mhm.
like some old like dinosaur who about to retire that's like gonna just talk at you and give you a bunch of medicines and then tell you to follow up with my nurse in 6 months. Like
Mhm.
I'm encouraging you to monitor your health, to take care of yourself, to learn more about whatever condition you might have. And I think that's why I also kind of gravitated towards rheumatology too. A lot of these conditions affect women in their 20s to 40s, and it is a very complex
Mhm.
pathology that a lot of people don't understand. I mean, you didn't even understand like what rheumatology was, period.
Exactly.
But I'm sure you've heard of rheumatoid arthritis. Like I'm
I
sure you've had
do. I
people,
do.
yeah, like
But
it's
like
it's a thing.
we didn't know like what exactly it entails of like, oh, okay, that's part of your job. We didn't know cuz like most people would just know general doctors, you know. And like some
Yeah.
people are actually afraid to go to the hospitals. They're afraid of freaking doctors. So,
Right.
I think your space would be like a good time, or a good representation of, like, hey, it's not bad to go to the hospital from time to time, take care of yourself, do medical checkups, because, like, it should be timely as well.
Yeah,
um
like if I can do this and somebody sees me and they're like, "Oh, that guy's a doctor and he's like a normal person,"
mm-hmm.
or he's like a mentally ill VTuber, but he still enjoys his hobbies. He still, is like a normal guy. Like I would be more comfortable seeing my doctor because of that or because of someone like that.
Yeah, and like, at least they would be aware of, like, things that you should know, like common misconceptions as well, things that you should not be afraid of going, why you need to go to the doctor. What's the difference of clinic and hospital? Okay, that struck me. So those things, I think your platform would be a nice touch for that, and hopefully um you give those information further. I think it would be a nice touch for you, and a lot of people would learn. I think that is things that we like. For me, um I have been aiming to making sure that at least when I do my podcast, like, people would learn as well, because there's not much um educational entertainers in the VTubing scene. So
Hmm.
I think I think us professionals doing that for the younger generations is like, you know kind of like a gift as well to them. And you have the audience learning from you. It's not just sometimes it's not just about gaming, and it's not just about the fun times. It's also nice to impart knowledge with them as well, right?
Hmm. Hmm.
Yeah. Okay, I'm not afraid of. Wait, I'm not afraid. I just don't have insurance. I think that's a. Mm, it's
That
sad.
is an American problem.
Yeah, I think some of us would have that. I mean, because in the Philippines we do have health cards now, especially for those who are working. So they have health cards to use, so that when they do have checkups, their medical things are accounted for by their company, stuff like that. But some don't really have those in some areas.
Yeah, and I mean, there are ups and downs to every system. As shitty as the American system is, if you do have an insurance that's able to plug you in with a specialist, I mean, you're able to see a specialist for like a fraction of the cost, maybe
Yeah,
like a $20 visit. But my ex is European, and she lived in a country with socialized healthcare. So I mean, you
good.
can
That's
get a
good for
doctor's
them.
appointment, you can get seen in the hospital for any complications. But if you need to see a specialist, if you need to see a neurologist, if you need to see a rheumatologist, like it takes like 8 months, 9 months to even get your appointment like
What?
scheduled.
That's so
Because
long.
yeah, I mean, it's the wait times to go see a specialist is crazy over there. So their primary care system, the doctors have to be more aware of like how to manage these conditions without a specialist on board.
Wow. So they're like, what, they need to be like general doctors so
Like the
that they
general
can.
doctors are managing them with the general medications too,
Uh-huh.
before they can see the specialists with that can offer these specialized medications.
No, tiny, that is dangerous. That wait time is dangerous, cuz like if you're already feeling something not fine with you, you should at least, have that one checked up. And like you'll never know, that long time frame can be, what if your condition progressed and like you get worse. I think that is dangerous. uh please look up your specific state health department website for details. That is good advice, Rico. Thank you. I think I would advise that to like Filipinos as well. Like, um, there's nothing, there's nothing wrong to search for if you can get assistance with the government. And then and you know if it's possible, try to use that. Don't um please use your government uh benefits because that's there for you.
Well, for us in America, government benefits don't kick in until you're 65.
Wait, what? Really? You have to be that
Yeah,
old? What?
so
So if you're
so
young, you're
I'm
done for?
reading, if you're young, and then you really are at the mercy of if you have insurance or if your insurance company is accepted by a certain specialist.
Oh my
So
god.
I'm reading a snippet from
Uh-huh.
an article right here. In a budget-based socialized healthcare system, there are often extended wait times, and those wait times can be extreme. For example, according to the Fraser Institute, the mean waiting time in Canada
Mm-hmm.
between a referral from a general practitioner to a specialized procedure is 19.8 weeks. That means that your primary care doctor could identify an issue that you urgently need fixed, and on average, it would almost take 5 months until you could see a specialist and have the necessary procedure done.
Oh my god,
That
that's so
number
long.
fluctuates by specialty. The average waiting time for an orthopedist is 39 weeks, while an oncology visit average about 4 weeks. And this contrasts with the American system, where the average waiting time for a specialist is less than 20 days. And in most cases, when covered by a plan with effective care management, could only be a couple days. In the PPO system, what is that called? PPO is
Mm-hmm.
preferred provider organization that most of the US functions in today. Specialist visits do not require any sort of prior authorization, but rather just need to be scheduled by the doctor in an open slot. Yeah. So for us in America, visits with specialists is really only gated by, is the specialist available? Do they have an open appointment?
Mm-hmm.
But in a socialized healthcare system, a visit to the specialist takes up a resource that the greater government insurance has to, pay for and deal with.
Mm-hmm.
So the wait times are so long because somebody is paying for your visit on the back end. Whereas in America, if you have your own private insurance, then your doctor just needs to schedule you the next time that they're available. So that's the differences in the system.
Wow, that takes so long. I think the insurance thing on yours is actually very similar to like the health cards that we have. So in the Philippines, health cards would be, I think, that pass for you. Like you don't have to um you just need to schedule an appointment, and then health card insurance that health card would do the things at the back end, and like you can just do your stuff whenever. Like you just
But
show
does
that card.
everybody have a health card?
That's the thing. Not everyone would have that. Most of
Yeah.
the time, those are available for those who are already working, like in a company, private companies.
Mhm.
But like
Mhm.
in general, person, not everyone would have that. They can avail it if they can, even though they're not working for a certain company. But like if not, then everything's just going to be from the
Out
government.
of your pocket.
Yeah,
Oh,
and
from
out
the
of
government?
from the government and out of your pocket.
Okay. Yeah. So for us, it would be, yeah, most people with jobs with companies will get insurance provided by the company.
Mm-hmm.
And then people who are on limited contracts or limited jobs, like maybe they drive for Uber or
Mm-hmm.
they work at like a small business, they are forced to find their own insurance because their job doesn't provide them insurance.
Mm-hmm.
And then people who are unemployed or people who are not in school
Yeah.
won't have any insurance. And then
At
the
all?
entire, yeah, like no insurance, period. We don't have any government benefits for them until they turn 65. So for them,
What?
those doctor's visits and the cost of those medicines come entirely out of their own bank account.
Oh
Like
my
that's
god.
100% on them to pay. Yeah.
That is so bad. Like they could you guys should have at least like, for everyone, not just for what when you're
Yeah,
old.
and I mean realistically, if this is like a 23-year-old, 23-year-old guy who goes to the doctors and fills out like a asthma inhaler,
Mm-hmm.
gets some labs done, like the visit, a level 4 new patient or returning patient visit, I mean, you would bill the clinic $200. And yeah, they'd probably be responsible for $200. But that's like a clinic visit in the office. Now imagine if the same guy was hospitalized for COVID in the hospital, had an extended ICU stay for 2 weeks, 3 weeks,
Mm-mm.
when, needed a bunch of rehab after that until they could breathe normally again, needed to get back on their feet again.
Mm-hmm.
Ultimately that's like a 6-month healthcare cost burden.
Wow.
The average hospital stay, like the night rate, like each hospital stay is almost like I don't know, like $6,000 or something.
What?
Like when you bill for everything in total. And it's like like some hospitals after a certain point just default on it and just pay for the stay themselves, because you can't expect somebody to pay like a $60,000 hospital bill if they don't have a job, right?
Mm-hmm.
So,
Wow,
I mean,
that's
some
so
hospitals
bad.
do end up defaulting on these patients, or and allowing the hospital to pay for the hospital stay instead.
Mm-hmm.
But, sometimes, like, yeah, like if this guy has a job and they have insurance, then the insurance only covers maybe 20% of the hospital visit. The patient is still responsible for like the other
Other medic
30,000,
yeah.
$40,000. And that's devastating to families sometimes because they have insurance,
Yeah.
but it doesn't cover all of it. And they had a very complicated, complex problem, and they were using up resources,
Mm-hmm.
being seen by multiple doctors, multiple specialists. So, yeah.
God, that is bad. That is devastating. It is. Oh, well, hopefully.
Well,
I can't say. I mean, like, I think the just the common ground would be like, hopefully, it gets better with, I don't know, like a lot of, I don't I don't want I don't want to have I don't want it to be like, something like a bad vibes, but like, sometimes reality sucks, and I guess hopefully we just need to be hopeful of like, hopefully it gets better soon. Maybe we'll have better benefits and all, um but yeah, try to stay healthy, people. So
yeah. And it sucks in America because healthcare becomes a political issue
yeah,
rather than a medical issue.
exactly.
So, yeah, depending on who ends up running the country, healthcare can look drastically different from one era to another era.
Yeah,
Yep.
budgets. But it is what it is.
It is what it is.
Yeah, we just have to cope up with whatever decision's gonna be. But anyway, let's move on. We don't want to dive in too much about that, but we do know that it sucks. But we do hope that, everyone can stay healthy, and um you know hopefully it gets better. That's all what we're gonna be wishing for anyway. So yeah, thank you for diving into that as well. But okay, just, oh my god, it's already almost 2 hours. Sorry to keep you up too long.
It's okay.
Are you okay? Are you still okay? Do you need rest, doctor? Do you, I mean,
I can go for like another 30 minutes. I'd be fine with that.
okay. All right. Thank you so much. All right. I guess I'll skip to a couple of things then, since we have discussed some of this one already, or we did had a touch base on it. Um, I ask this question every time to everyone. Can you tell me if is you streaming a secret?
It's not like entirely a secret. I mean, I think all of my friends know that I do this. I post about it on like my Instagram sometimes. Not
Really?
like I'm live every single time, but if I'm in a cover or something, I'll like post
Mm-hmm.
on like my story and I'll be like, "Yeah, check this out."
Oh wait,
There
so
are
your
two.
IRL friends know.
Yeah, like more than a few, but I mean, it's not
Oh.
like I've outright said like "Catch me live at PsyCanMD."
Mm-hmm.
There are two people in my hospital who know that I do this, and none of them are in my year. They're like, one of them is a second year and one of them is a first year.
Oh, so they.
Um,
Mm-hmm.
because they're nerds and we play games together, and yeah. So of course they're gonna see me on Discord and like, wait, he's streaming? What?
Wait, so are they like just technically? Are they like friends then? That or
Well, one of them is a
acquaintance?
friend. The first year is an intern that I got into my program,
Oh.
who is also a Doctor Vtuber.
Wait, no way. It's
Yeah, I don't think she
re-
wants people to know that we work at the same hospital though, but we are in the same hospital.
okay, but at least you guys relate that you guys are, at least
Yeah,
but
like we met on like VTuber Twitter, and then we're like, "You're a doctor?" And I was like, "Yeah." And she's like, "I'm
what?
I'm in medical school." And then I like got her into my program in my hospital.
Oh my god. That is oh my god, that's so cute though. Meeting
Yeah.
somebody, meeting another VTuber and then like not knowing they're a VTuber and then wait, you are a
Getting
VTuber. Yeah,
getting
getting
career advice out of them and then getting into their program out of them.
exactly. Oh my god. Okay, thank you. Wait, do you guys stream together or like
No, she hasn't streamed since graduating med school. Like she's an intern still, and
uh-huh.
she's not as crazy as I am to keep streaming like this. So
Ah, I see, I see. But I'm happy that at least you got the time. I know, we know that you're busy. As you did say about your schedule earlier. God, just one
yeah, I mean,
off.
it's not like I'm perfect. I mean, I still sacrifice sleep, you know,
Who needs to leave?
healthy meals and stuff. I
Mm-hmm.
live I live alone, I order food
Ah.
more than I should.
Yeah, yeah.
But I mean, again, streaming and, playing games is something that's always been important to me my whole life. So even if I'm doctoring or whatever, it's always something
Mm-hmm.
that I'm going to try to carve out time for in
Mm-hmm.
my life to do.
Hooray! I'm not gonna say hooray nerds. Yes, we're nerds. I know. But like, um. Anyway, okay. Just the next one. I'm gonna fast pass this for us. Can you tell us? Is there any interesting medical cases you can share with us that you think like really struck you?
Yeah, so I had a patient this past weekend actually
Mm-hmm.
that we admitted maybe the other week and was doing very well. He came in with a small bowel obstruction, so a part of his intestines was blocked off by something in his abdomen,
Oh,
and he was admitted. He had the surgery to fix it,
yeah,
and he was just recovering on the floor and doing fine. And this guy was like maybe 4 or 5 days out from the surgery.
yeah,
And then all of a sudden, one overnight, Sunday into, or like Saturday into Sunday or Sunday into Monday, I don't remember. But,
yeah.
he developed like a very severe complication during his recovery, got very
Oh,
sick overnight and turned like extremely downturned into like a very septic, like emergent case.
oh my
And then
God.
he ended up having an emergency surgery, and the findings from that emergency surgery were like inoperable, unable to survive the operation, and then he ended up dying in the
What?
OR. So, it's always that kind of reminder that like we can do everything right, and then you think that somebody's recovering very well, you're monitoring them for almost like 5 days and
Mm,
they're doing great,
yeah.
and then just one complication happens overnight. Like it's nobody's fault, like it's just a catastrophic complication, but that thing just happens, and then they just take a downturn and they go from great to unstable to critical. Then they go for a surgery and the surgeon says
Wow.
like it's inoperable, and then they end up expiring in the OR. Like it's always just like that one case every month, that you just think about, right? Like you can't get complacent in the hospital, right? Like you just think, okay, I'm
Mm,
gonna treat this, lady for a pneumonia.
yeah.
We'll be here for 3 or 4 days and then we'll go home, right? But you always
Yeah,
got to
yeah.
think, what if, in the back of my head, if this goes poorly, what are my backup options? Like, what's the next step?
Mm.
So, even if you think the most stable patient who already had the surgery 5 days ago, like nothing can happen with him. He's almost better. He's going to walk out of here tomorrow.
Yeah.
Like something terrible still can happen. And like you just want to make
God.
sure that you always have all of your bases covered.
Oh my god. That's gonna be, I think, like, for me, this is gonna be such a shock as well. Cause like, oh my god. Just a few days
Yeah,
after? Oh my,
just a
and
few days, and
what
it's
the,
like you start beating yourself up for like small mistakes that you did. Probably
yeah.
not relevant to the overall cause. Like he just had a catastrophic sudden complication, but when I brought him to the ICU for the first time, I was
Yeah.
thinking like, fuck, like I didn't manage his volume status correctly. Like he was still outputting a lot more than he
Mm.
was getting intake for. I was managing his pain well, but then his kidneys were also taking a hit. These like small things that in the grand scheme of things had nothing to do with the way that he ended up passing away.
Yeah.
But it's just like things that you could have thought that you could have done better. So I mean,
You
yeah, the
mhm.
most stable patient, you can't get complacent with their care, and you can't just copy and paste all of the orders from the previous day. Like you always need
Mhm.
to think about what you could have done, better.
Yeah.
So
But like, I guess at that point you nitpick like whatever things you guys did feel like, you know.
or the
Uh
fact that nitpicking doesn't even matter because even if I did keep his kidneys in a better condition, or even if I did
mm,
monitor his intake and gave him more fluids than I was giving in that situation, I mean he still would have developed this surgical complication.
yeah.
And it just happened so close overnight, like from a
Mm,
period of like 6 hours from 2 a.m. to 8 a.m. And then boom.
mm,
Yeah.
yeah. Wow. Head pats, doctor.
it's
Hopefully
it's
it
okay.
doesn't, I think it does happen on, like, I think for me, like, doctors would always have this thing with life that everything's just gonna be, it's not, it's like you guys always have a thin line with life, like everything's gonna be, um making sure that, making sure that it's, make sure that your patients are like alive and well, and like you guys will do everything. But like, even if after all of those efforts, if somebody, expire and like pass away, it will always, like, hit on you.
Yeah.
Yeah.
And I think that we just have like a different way of looking at death in that sense,
Yeah, exactly.
because it's not, sometimes death isn't like a complication, it's just the natural progression of whatever happened. And
Mm-hmm.
the medicines and the treatment that we gave could prolong life and stave off death, knowing that we could not cure the process,
Yeah.
but we made them comfortable. We gave them the treatments that they needed to, buy an extra
Mm-hmm.
month, buy an extra few weeks and stuff.
Mm-hmm.
So, I mean, it's not like I don't care about life, but
Mm-hmm.
I think I'm more accepting of death than most other people are.
Mm-hmm.
Or like I'm more comfortable with approaching, the idea of it,
Mm-hmm. And it's,
because I think a lot of people our age would probably be like, I don't want to think about dying, like I don't want to think about blah blah blah. But I mean,
mm-hmm.
I've seen it enough times to know, like, what families go through,
Yeah.
what happens. I mean, I think there's a clip on Scrubs where like
Mm-hmm.
he points to a surgeon and he's like, I don't know, Dr. Wong has to tell that family that their son is dead, and
Yeah.
then he's not going to make it, and then he's going to eat lunch and go back to work. Like, do you think anybody else in that room is going to go back to work? No, but like we have to, right? So
Mm-hmm.
there's a part where you can't take it all with you. You just take kind of the lessons and you process that emotional response. But you mean you still have 21 other patients to see that day. So when the emergency is over and the dust is settled, like you still have other people who didn't demand your help and stuff. So
Yeah. That, I think for me that's going to be like one of the hardest thing as a doctor, like, knowing, um knowing that you have to still go on regardless, because other people would still need help, and you can't, You can't just get hung up with one death or like a patient of yours. I think
Hmm.
I think I actually watched that from so I've been watching House MD. I'm on season 3. And I think one of the things that I actually liked from the show was like, um like people are trying to like make sure that people are alive, but at the same time, like doctors would be, or him or House would be hung up on like what did he do wrong, or what could have been. He needs to know what happens so that it won't happen again. And I think that's like a good trait for any doctors, because like experience would also get you into knowing uh what would be the best course for a patient. So because they've been
Yeah, I think
having their
there's definitely
question.
like a season. There's a season 2 episode about that too. It's
Yeah.
like he's treating this kid with this extremely rare disease, but then
Yeah.
he like digs up in his charts like this 80-year-old patient
That
who died
one.
from the same disease, and then he's like,
Exactly.
"I've seen this one before."
Yeah. Cuz and like people were like telling him, don't get hung up on like, this 80-year-old patient that you weren't able to cure. But he was like, no, I know this happened. And he's like, really digging into it. I think like for me that's like one of the episodes that really hung up on me, because like he knows what he's doing. He knows that patient, got that patient struck him, and he's now going to make sure that this won't happen again to a younger patient that has the freaking same symptoms, like everything. And like, I don't know, it was I actually love that episode. Thank you for pointing that one out. But yeah, I have
Yeah,
been
because
I have been
my friends are rewatching House too, so I've been watching it with them.
Hey, let's go. I think House
And
is
like I
actually nice.
House is the first medical drama that I watched. It is
Ooh,
definitely not the most realistic. I still think Scrubs
yeah.
is the most realistic, but House is like a good drama, and it's fun.
Mm-hmm.
My problem with it is that the medicine of how, because it's a drama primarily, the
Mm.
medicine is like very elementary a lot of the times.
Really?
Like the medicine parts, the patients will have very complex presentations, but it's always like House has this brain blast moment like 45 minutes into the episode where he makes a diagnosis, but like
Yeah.
anybody could make the diagnosis because they always use like the most obvious clue. Like if you ask any medical student, like
Mm-hmm.
a guy comes in with a fungal infection, he's a rose gardener,
Yeah.
and he's got a serpiginous rash on his arm. Like any medical student is gonna say like, oh, boom, sporotrichosis. Like everybody knows that because like that's like the buzzword that you know. In real life,
Mm.
probably most people with sporotrichosis are not rose gardeners that handle roses on the daily. But like in the
Oh,
house episode,
they
they'll
would
come
say
in with like
that.
the constellation of symptoms, and then
Ah.
45 minutes into the episode, the patient will be like, "Oh man, I can't believe I bought those roses for my girlfriend last week." And then House will be like, "What do you mean you bought roses? Sporotrichosis." And
Like
then
you just
like,
know.
yeah. Like of course it's sporotrichosis. Like what other disease is associated with rose prick and infections? Like it is very like disgustingly obvious when it does happen,
Uh-huh.
but like the fun of the show is in the drama and everything, so
Exactly.
I that's what I do like.
Mm-hmm. It gets very
It's
dramatic,
not
really.
realistic at all though.
Really? Oh my god.
Well, I mean, like, why the fuck? Like, dude, like in the first like 3 seasons, Chase, Allison, and Chase, Cameron, and Foreman,
Cameron.
they like do all of their own labs. They do all of their own surgeries. They
Yeah.
do all of their. I'm like, where are the nurses in this show? Like, are you telling me that these are also like simultaneously infectious disease, neurosurgery, allergy, immunology, nephrologists? Like, it's like there's no other characters in the show, and
It's
because of
just
that, they
them.
don't have any other doctors. Like they do everything.
It's I think like for me, like the thing as well on the show was like everything's just complicated, and then like at the last minute it would just be such a common thing, and like,
Yeah, they'll give away the most obvious clue, and then they'll be
yeah.
like, "Oh, of course it's this." I'm like, "Yeah, anybody could get that."
But yeah, it's been a fun show. I've been watching it.
I really like season 4,
Season
so
4.
you're almost there.
Okay. I do like their discussion though, like the board, the whiteboard, and then like,
Yeah,
they're
that's like how we
discussing
do
like,
differentials and stuff. Yeah,
yeah, I really like that part. Like the thing that they have to, oppose each other. No, this is the thing, and then no, this is what the Simpsons is, things like that. It was nice. When was your last stick? What do you mean last stick?
like the last time I did an IV stick, because like I was
Ah.
saying earlier, like I don't. So Rico's a nurse, right? Like I don't.
Oh wait, Rico's a
I
nurse?
don't do like I don't do IV
Hey!
sticks. Like I don't. I think I practiced. I practiced like in med school. I think I had to do 5,
Uh-huh.
and then I think I did 1 in the ICU last year, just during like a code situation. But I don't like. I can count on one hand how many I've done as a doctor. Yeah,
Well,
and he also made a video about that too. You know, like
really?
grumpy patients that are like, I don't want a
Oh!
nurse to do my IV. I want the doctor to do the IV. And then I'll be like, I haven't done an IV in like 3 years. Like, what? That's not my job.
Oh! Wait, that's something to debunk. Okay, I was actually gonna ask you
Oh, is
about
that the
next.
debunk question? Yeah.
Yeah, because like I've been seeing a lot on TikTok of like, patients would always be, I don't know, patients sometimes don't trust their nurses, and like, bruh,
Right?
their
It's
nurses are
not
like
like
there
they're
for you.
less educated than doctors. Their
Exactly.
education is just in a different part of medicine. Like I said, I have no idea how to hang up bags and use like infusion pumps and stuff, or like I have no idea how to like manage stuff at bedside, like change out different IV lines and do dressings and stuff.
Mm-hmm.
Patients wouldn't survive in the hospital if they didn't have these things too. So like as much as my expertise and knowledge is needed to diagnose and treat the condition,
Mm-hmm.
I need a nurse's expertise and knowledge to, actually physically deliver those treatments to the patient.
Exactly. And like, patient the nurses are the one who takes care of you. Why would you not trust your
Yeah.
nurse?
So like I said, most of my day is seeing 22 patients, and then
Checking up with their
I
nurses.
see them 15, 20 minutes during the morning, and then I
Yeah.
check on them like 5, 10 minutes in the afternoon, and then I see them the next day.
And that's
But the
it?
nurse is on the floor seeing them and dealing with them physically all day, like in the same unit, in the same bed, checking up on
Yeah.
them every so and so hours, changing out their meds, changing out the bags,
Uh-huh.
dressing them, making sure they do these things. So it's like it's they have more physical patient time than we do.
Mm-hmm.
But I think people just conflate that, like, oh, doctors know everything, and then nurses are just like the employees to take the orders. But like, that's definitely not how it works. So, yeah, that's my medical misconception that I'm debunking.
Good. That is a good debunk, actually. And Rico, wait, what is your IV short? What do you mean?
Oh, he made a short about like,
Ah.
I don't want the nurse to do my IV. I want the doctor to do my IV. And he's like, the
I
doctor
see
hasn't
that
done an
one.
IV since medical school. And I was like, yep, I haven't done an IV since medical school either.
I see. But you can share. I think wait, I can't. I don't have hyperlinks on my chat, sadly. But I think I'll check on it. Yeah, we'll share it later. Maybe on one of our links on when I upload the when I upload this on YT or here later. I'll search for it. But yeah, thank you. That was a good misconception to debunk, because I think a lot of people are like just knowing, hey, doctor knows everything. The nurses are just there. But please appreciate, viewers. Please appreciate your nurses. as well. They're there to help you out. And they study med school, or they study medicine too. It's not like, they're gonna be there just because they're qualified to do so. So, yeah. All right. Okay, next question. I think this is going to be last two, more or less. But
All right, I'm ready.
can you tell us any tips for people who wish to be on the medical field as you?
Yeah. I mean, I guess this might be more relevant for Americans, but it is a job that demands a lot of you, and you really should get into medicine because you think being a doctor is the coolest job ever. Like,
Mm-hmm.
yes, you will make a lot of money in this country as a doctor. Even if you do the bare minimum, graduate, do a residency, and then go straight into your first job, like you will still make more money than
The
my
usual.
parents make, and like 95% of this country makes. Like, you will have a good house, you will pay back your loans, you'll have a good lifestyle, but none of that really means anything if you don't enjoy talking to patients, if you don't enjoy treating people. I think a lot of people kind of get into medicine because, oh yeah, I'm good at science, but then they're awkward as hell, and like they don't talk to patients well. Like, it takes a certain kind of person, it takes a certain kind of personality that you are interacting with people on a daily basis. Like, I really don't talk at my patients. Like, I try to listen to them and have a conversation with them,
Mm-hmm.
and I try to educate them about their disease more than like say, hey, you have this in your blood, so I'm treating you with this. All right, let me know if you develop any cramping or nausea. All right, bye. Because I feel like, some of the
Mm-hmm.
older doctors that you see in the hospital, like that's how they practice. But
Yeah.
I really think there should be, in the modern era, I think a lot more people, are on TikTok, are on YouTube, are watching videos about, people having more agency over their health,
Mm-hmm.
right? And having these conversations with their doctors, right? Yeah, sometimes they're completely wrong, right? Like, yeah, like sometimes you have to debunk that, like, okay, vaccines don't cause autism. You know, you don't need to
Oh
take
my god, that
ivermectin
one.
for COVID.
Good.
This saw palmetto supplement doesn't do anything for your,
Mm-hmm.
cancer, but it's going to increase your risk of bleeding. So please stop taking it. But like a lot of times people just want to know how to take care of themselves and like how to best take care of themselves. So if you
Mm-hmm.
can't have like basic conversations and like empathize with people, like, I don't care how good your board scores are or how well your standardized tests were, like, you probably shouldn't go to medical school. There are so many other applications of science that don't involve talking to patients as a doctor and being a doctor. I think a lot of people chase this for the money and the prestige. Like,
Mm-hmm.
okay, one, for starters, the money dried up a long time ago. Like, if you wanted to be a doctor and make a ton of money, like, the time to do that was in the 90s and the 80s.
Mm-hmm.
Nowadays, like, with how our current political situation is, like, it's not, I mean, it's profitable, but it's not as great as it was. And two, like, nobody really cares about the prestige anymore. I don't think it's that special. I feel like you get points with like your mother-in-law or father-in-law being to say like, oh, my kid is dating a doctor, but I mean, like,
Uh-huh.
nobody's getting you don't get like discounts, or like, you don't get to cut in line. You don't nobody like, nobody cares.
Mm-hmm.
Like, I think people who end up becoming doctors think that they're a bigger deal than they really are. Like, it's just a job, dude. And I think people should realize that before they sign away 14 years of their life into training and going into this field.
Mm-hmm. I mean, it does have a nice ring calling someone, hey, doctor, doctor that, doctor this. And yeah, it does score points with mother-in-laws, so
Yeah, I know. But even like when I'm on the floor and like the nurses call me like
mm,
doctor, like, last name,
yeah.
I'm like, don't call me that. Like, just call me by my first name. Like, dude, we're like the same age. It's weird.
I see. Well, here's your modern doctor, Saikin. I feel like you're a very cool doctor in the hospital. I
Yeah,
don't know.
I'm pretty cool. Yeah, I know. People like
Wait.
working with me. I'm kind of a big deal.
I just feel like you're very like right now you're very empathetic, and I think that's a really good trait as a doctor, because things can be very very hard in the hospital, and people need someone who can listen to them and like be there to say that we will try our best, and at least still be realistic and of some sort, but like still have the care. I think that's what people usually needs, when they're in the hospital, like just knowing
Yeah,
somebody
yeah.
cares for you.
Yeah, and it's not just like a guy that comes in every morning and tells you what they're going to do and then leaves the room and you still have a
Yeah.
bunch of questions to ask. Like
Uh-huh.
I think interacting with patients in a way that gives them agency over their own health
Mm-hmm.
and their own, the decisions and the medications that they're getting, I think they deserve to have it explained to them
Yeah.
and, understanding their condition so that they can take care of themselves better once they are out of your care in the hospital, right? I mean, just because I
Exactly.
take care of something now, that diagnosis, that problem might still linger with them for the next 10, 20 years, right? You
Mm-hmm.
don't just magically, recover from heart failure overnight. Like, you're going to have to take medicines for quite a while. So, if you understand what those medicines are, you understand why you take them, you are
Mm-hmm.
probably more likely to take those medicines instead of just skipping them and be like, I don't need this. I feel fine today, blah, blah, blah. Because my dad does that and it pisses me off.
Well, at least at least we know better. And I don't know, like I feel like sometimes reassurances from doctors is a big help for patients. And yeah, I wouldn't. I will say don't worry, because like, oh my god, it's 5 minutes. All right, one last thing. Can you tell us?
Okay, okay.
I want to talk more, but like I know you're also tired. So any messages for your viewers, Doctor?
Messages for my viewers.
Yeah.
Please go see your primary care doctor. Um, I guess for an impassioned plea, my personal tip for a lot of people, people who say they don't have insurance, they don't want to pay hundreds of dollars for a doctor's visit and get diagnosed with something and have to pay another $100 for medication.
Mm-hmm.
My life hack kind of tip has always been to go see a residency clinic, affiliated with their local university. Because, people like me work at these sort of safety net clinics with zero, funding because that's like places that we have to train at. And you can be seen by a primary care doctor who is a resident who's underneath a supervising attending. And like my clinic, it is a safety net clinic for the community, which means it is for people who don't have insurance, people who aren't able to be seen by a conventional, like fancy primary care doctor. I would Google up your local university and type in like University of blah, 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 family medicine residency or internal medicine residency, and you can kind of stalk their website and see what clinic sites that their residents train at. Because, yeah, they'll probably be in the university hospital, but they're definitely not working in the university clinic. Like, they're probably working at like a clinic down the street with
Mm-hmm.
like 12 employees total and like two bathrooms that are run down and like a really sketchy like front logo that's like a knockoff of something they found on Google Images.
Uh-huh.
But it is like a community resource for that. And as an uninsured patient in the community, like you are the target demographic for that. My community like clinic also has a sliding scale pharmacy. So even very expensive medications in America, things like insulin or like certain, heart medications, I'm able to give patients at an adjusted price instead of them paying right out of pocket. So it kind of
Mm-hmm.
scales to their current income. So even if I needed to put somebody on $1,000 medication, if they fill it out at our pharmacy after seeing me at the clinic visit, they can get it for maybe 20 bucks a month, like because it's adjusted to, how much money they make. So,
Aw. That is so helpful for everyone. Please do so. And thank you, Rico, for telling us community public health clinics are usually free too. Hey, see, for everyone, they could be helped. I think some people just need to research. And, that's why we're also here to make awareness so that you'll know and you can do it.
Yeah, and this isn't just for like medicine too. Like helped my friend find like psychiatry near them as well.
Yeah.
Like the university had a psychiatry residency program, and their psychiatry residents rotated at like a mental health clinic like in the area too. And it wasn't affiliated with the university, but the residents of that program had to train in the clinic setting, and they trained at this community center.
Mm-hmm.
And I was able to give them their website and tell them like, hey, call this place and make an appointment there. And then they were able to get started on like seeing a psychiatrist, seeing therapist, getting these psychiatric medicines and everything, and get
Mm-hmm.
their conditions under control.
Um, Thank you. Thank you for that. And thank you for letting your viewers know. Thank you for um making us aware. And I'm happy that at least, we are able to share this information to them as well. People, I think for us, our mental health is not as, I don't know, it's not as looked properly here in the Philippines. But if you're having problems, please know there are also free facilities here. Your government facilities also has those free consultations for you, and please use your hotline. Um, they would help you, and you're not alone. Yeah, thank you so much, Dr.
Yeah.
Saikin, for all the information. I had fun. I actually have a lot more questions, but um, I don't want to keep you too long. Maybe next time. Maybe next time we can.
The sequel.
Maybe next time, or maybe we can go ahead and just maybe play and do discuss stuff sometime
Oh yeah,
soon.
with our 290 ping difference.
What Monster Hunter can be forgiving with pings? We'll see. I can go to your server. No problem with me. Anyway, but thank you so much for joining us on today's stream. I know it's already late for you and you need rest. You just got from you came in from work.
Yeah, I got off work.
I
I came home at like 7. I took an hour nap. I inhaled my leftovers, and I got on at 8:30.
Exactly. So I'm pretty sure
And
you're
then
you're
my
dead
friends want to
tired.
watch Arcane tonight, so that's gonna be like another hour and a half, 2 hours.
Oh my god. Please have
And
rest.
then I'm gonna go to bed. I promise. I promise.
Please have a rest, Doctor. A lot of people are counting on you. But yeah, thank you so much for giving me time to speak with you, to have you as a guest on my show. And I'm really happy to talk to you. I'm actually having fun. And I'm learning a lot. So thank you for educating us, making us aware of stuff. And I really had fun. I hope you did too.
You're welcome. Yeah, I mean, I like talking about my job. Like I said, like become a doctor because I think it's the coolest job in the world. I think it's the coolest job in the world.
Mm. And we can definitely see that. I can see that. I can really see that you are having fun. So yeah, thank you everyone for joining us on this podcast tonight. I will still be streaming, but I will be taking a break uh to get food as well because I haven't eaten anything aside from having coffee. But thank you everyone for joining us again. Please do follow us like NMD. I have his links pinned on our chat, so please go ahead and follow him. Follow him for more medical tips, medical information, education, and of course, he'll be having fun playing as well. So watch him. And yeah, I think that's it. Thank you so much, Saikin, for joining us, and I do hope you
Thank
have a good rest.
you.
Thank you, everyone. I'll go on break time. You guys have a break too. See you. Thank you. Bye.
Bye.